Hello, everyone. Welcome to the fourth meeting of the COVID-19 Health Equity Task Force. I am Captain Samuel Wu, and I am the designated federal officer for the task force. Even though we are near the end of the month, I would like still to wish everyone a happy Asian American, Native Hawaiian, and Pacific Islander Heritage Month. I also want to take this opportunity to thank Dr. Min Wen, who served as the designated federal officer for the last two meetings while I was on deployment. Also, I want to thank the leadership in the Office of Minority Health, Rear Admiral Felicia Collins, Captain Danny Nguyen, Ms. Rosin Moore, and Dr. Martin Mendoza for their support during my absence. As a reminder, this meeting is being live streamed and recorded and will be available for viewing at a later time. All materials presented in this meeting will be available on the task force's website at minorityhealth.hhs.gov/Health Equity Task Force. We are providing American Sign Language interpretation for those with hearing impairment. Closed captioning for this event is available at both the HHS live streaming channel and the Office of Minority Health YouTube channel. Members of the public have been invited to provide comments as stated in the meeting notice published in the Federal Register. Written comments will be accepted up to 7 days after the meeting. Please send comments to COVID-19 HETF at hhs.gov. With that, I turn it over to Dr. Marcella Nunez-Smith, Chair of the Task Force. Madam Chair, the floor is yours.
Thank you so much, Captain Wu. And hello, everyone. Let me add my welcome to the fourth meeting of the Federal COVID-19 Health Equity Task Force. The objective of today's meeting is to discuss interim task force recommendations to address xenophobia and discrimination. Xenophobia and discrimination drive COVID-19 and other health inequities at the structural level. A long history of racialized and targeted policies and practices in this country in housing, nutrition, education, healthcare, policing, immigration, and employment has functioned to marginalize too many, systematically limiting access to opportunity. And that history remains all too present in the current COVID-19 landscape. Communities of color have been overrepresented in COVID-19 infections, hospitalizations, and deaths, and underrepresented in access to life-saving therapies and vaccinations. The imperative is clear. We must name and urgently address these realities. As we prepare to turn to our work today, we acknowledge that just earlier this week marked 1 year since Mr. George Floyd was killed by Minneapolis police. This upcoming weekend marks 100 years since the Tulsa Race Massacre, in which a thriving Black community known as the Black Wall Street was violently destroyed by white residents. These anniversaries serve as solemn reminders that racism in this country has for centuries violently denied Black and other minoritized people the right to achieve their full potential. Generations of families have seen the conditions of their lives and of their communities shaped by structural and interpersonal racism. The year-long conversation, reckoning following the collective witnessing of Mr. Floyd's murder should be inseparable from our shared understanding of the effects of the COVID-19 pandemic and from our work on this task force. We simply cannot understand the tragedy and the toll of COVID-19 or prevent the predictability of this pattern in the future without looking toward its drastically unequal burden on communities of color. And over the past year, we have also been heartbroken and outraged at the increase in anti-Asian hate incidents we have also witnessed in businesses, on our streets, in schools, and disproportionately directed towards AANHPI women. While we know that the discrimination faced by the AANHPI community is not new, the COVID-19 pandemic has heightened inflammatory and xenophobic rhetoric and tragic action. In his very first week in office, President Biden issued a memorandum condemning racism, xenophobia, and intolerance against Asian Americans and Pacific Islanders and Native Hawaiians. This was followed by a Department of Justice whole agency initiative to address and prevent race-based hate crimes. The initiative includes community resources and outreach programs, strengthening of data collection and transparency, and law enforcement training to increase capacity and competency to report hate crimes motivated by anti-Asian bias. And these efforts were redoubled at the congressional level when the COVID-19 hate crimes bill passed with overwhelming support from both chambers of Congress. The legislation, which President Biden signed into effect, makes reporting of hate crimes more accessible, ensures reporting resources are available online in multiple languages, and authorizes grants to state and local governments to conduct programs to prevent and respond to hate crimes. And at the signing, President Biden acknowledged the deep roots of racism and xenophobia in our country and in our government, including anti-Semitism and Islamophobia. We also see growing recognition of the relevance and impact of discrimination on our health. Last month, the CDC declared racism a serious threat to the public's health, calling for the confrontation of the systems and policies that have resulted in the generational injustice that has given rise to modern-day racial ethnic health inequities. And the CDC is committed to recognizing and operationalizing work that demonstrates the profound and negative impacts of racism on the health of communities of color. Across the entire country, local and state leaders are declaring racism a public health crisis or emergency. That's 208 local and state government entities that in total have made this declaration, including 95 city and town councils, 45 county boards, 45 health entities, 14 governors and mayors, and 3 state legislatures. These efforts on the part of the CDC and local and state governments acknowledge that while the events of the past year have made us crucially aware of COVID's skewed toll on communities of color, there has never been a year in which these communities have not suffered disproportionate burdens of death and disease. And this affects the health of our entire nation. So a brief reminder of our charge. As a task force, we are charged with providing specific recommendations to the president through the coordinator of the COVID-19 response and counselor to the president to mitigate the health and social inequities made all the more evident by the pandemic and that are driving unequal burden of disease risk, suffering, and sequelae in minoritized, marginalized, and medically underserved communities. And as we hold our work as a task force, we are always mindful of that broad lens that is needed to be able to center equity across all of the most affected groups. People with disabilities, those who are justice involved, older adults, our rural neighbors, mixed status families, queer and gender diverse people, people of color, indigenous and native people, and those who are struggling on the margins of the economy. Experiences of discrimination touch all of their lives. And on the data front, we will continue to call for the complete disaggregated and intersectional data that are necessary to guide a data-driven approach that will enable health systems, organizations, and communities to respond to COVID-19 and combat racism, xenophobia, and discrimination. In doing this work, we will always continue to elevate the wisdom that is too often ignored or undervalued in marginalized communities as we generate recommendations and guidance. Again, the focus of today's meeting is xenophobia and discrimination. Our past meetings have discussed the data necessary to drive an equitable response and recovery, equitable access to vaccination and vaccination confidence, and behavioral health. Today, as a task force, we will deliberate interim recommendations that may be modified ahead of the final report. In our agenda, we are pleased to welcome Surgeon General Murthy, who will share his perspectives and priorities with us today. We also welcome two luminary experts in the field, Dr. Winston Wong and Dr. David Williams. They will provide additional context for our discussion today. So thank you in advance to our guests. We'll also officially welcome and introduce a new ex officio member to the task force. The work of the task force, is organized across 4 subcommittees: communications and collaboration, data, analytics and research, healthcare access and quality, and structural drivers and xenophobia. In the second half of our meeting, each of the 4 task force subcommittees will share interim recommendations for group consideration ahead of public comment. We will then deliberate further as needed ahead of task force voting. So in closing, I want to extend my deep appreciation to the federal staff team, to the task force members. Your commitment to this work is nothing short of inspiring. And thank you to the many subject matter experts who met with the task force over these past weeks. Now I'll turn it back to you for the roll call, Captain Wu, and welcome back.
Thank you, Madam Chair. Now I will conduct a member roll call. This is for the meeting record. When I call your name, you may respond with present. Ms. Myra Alvarez.
Present.
Dr. Sarah Blythe.
Present.
Dr. Jessica Cardy-Shawn. Dr. Richard Cho. Dr. Pritesh Gandhi.
Present.
Dr. James Hildreth.
Present.
Mr. Andrew Imperato.
Present.
Mr. Victor Joseph.
Present.
Ms. Jo Linda Johnson. Dr. Jonay Caldoon.
Present.
Dr. Rachel Levine.
Present.
Dr. Octavio Martinez.
Present.
Dr. Marcela Nunes Smith.
Present.
Dr. Tim Putnam.
Present.
Mr. Vincent Torrenzo.
Present.
Ms. Mary Turner. Dr. Homer Venters.
Present.
Mr. Bobby Watts.
Present.
Ms. Hae-Young Yoon.
Present.
Madam Chair, we have a quorum for the meeting.
Thank you so much, Captain Wu. It is my pleasure now to bring into conversation our Surgeon General, Dr. Vivek Murthy. Thank you so much for joining us, Dr. Murthy. I'll quickly introduce you and then really want to hear your thoughts today. So Dr. Vivek Murthy is the 21st Surgeon General of the United States as a returning role, previously serving as the 19th Surgeon General. As the nation's doctor, the Surgeon General's mission is to restore trust by relying on the best scientific information available, providing clear, consistent guidance and resources for the public, and always ensuring that we reach our most vulnerable communities. As the Vice Admiral of the U.S. Public Health Service Commission Corps, Dr. Murthy commands a uniformed service of 6,000 dedicated public health officers serving the most underserved and vulnerable populations domestically and abroad. So good afternoon, Dr. Murthy. Thank you again for joining us for today's task force meeting. This is a really crucial conversation for us to have. When it comes to the pandemic and COVID-19, we have come really so far from where we were just a year ago. But on the other hand, we've had another reckoning in this country, and that is one of targeted hate. So I know, having known you for a long time, just how deeply you care about creating community, about feeling fulfilled in the relationships that we build. And you have talked extensively about what happens to us when those bonds are frayed or broken. So welcome.
Thank you so much, Marcella. It's so good to see you here, and I'm grateful for the opportunity to be here with everyone who's part of this task force. And I'm just so glad that the president chose you to lead this effort, given your expertise, your sensitivity, and just what an extraordinary leader you've been over the years. So thanks, Marcella, for having me.
Appreciate that. Thank you. So, Dr. Murthy, as we are bringing AANHPI Heritage Month to a close, if you'd be willing to talk to us just a little bit about your personal and your professional experiences during or even before the pandemic, and really importantly, how those experiences inform your work, on the topic of human connection.
Well, I appreciate that, and please feel free to call me Vivek. I'm pretty informal, as all of you guys might know. But it's a great question, and I do think your framing of this in the beginning was exactly right. The pandemic we hear about is the COVID pandemic, but this deeper wave of racism and xenophobia that has once again resurfaced in many corners and accelerated in other corners. That has impacted people's lives in ways that are also profound, but not always acknowledged. In terms of my personal experiences, pre-pandemic, like many immigrants who've come to this country, or people, whether we came here a few generations ago or a few years ago, if you look different, if you have different customs, it's not always easy to fit in. And I certainly felt that as a young kid growing up in Miami, where we were really blessed to have teachers and neighbors who looked out for us and embraced us and welcomed us. But there were many instances as a young child where I was reminded that I was not necessarily the same as others, and where I felt like an outsider. And there were small incidents. And I think many of us, maybe when we were kids, may have had those experiences where we felt different, and they may have been benign, but they stick with you. I'll share one simple example. I remember taking some food actually to class for the entire class. It was routine that kids would bring cupcakes on their birthday that their parents would make to distribute to all the other kids. And my mother, us being an Indian family, my mom and dad used to make a whole bunch of different types of Indian sweets. And this one day in particular, my mom said, well, why don't you take some sweets to school and I'll make some jalebi for you. And for those of you who have had jalebi, it's a sweet that's orange usually, and it almost looks like a pretzel, but with even more circles and sort of contours to it. And it's really, really sweet, actually. So I was so excited, and I took this huge box, of jalebi to the class, and very proudly distributed it to each kid with a napkin. And then I waited for people to say, "Oh my God, this is amazing!" But in fact, instead the reactions were like, "Oh, what is this? This tastes like so terribly sweet. It tastes like plastic. I don't like this. I'm going to throw it away." And it was fine, people weren't used to it. But I remember as a young child at that time thinking, there's something that I thought, we had at home, which was just, commonplace. But I guess, we're really different in some ways. And that was fairly benign. But then later, in childhood, they were more, I think, more concerning incidents that I experienced, like many other kids, of sort of being ridiculed or picked on because of my heritage or the color of my skin, or the fact I had a name that was hard to pronounce. And again, issues that don't feel that big of a deal now, like when I look at it the several decades past, but were actually moments that reminded me that I didn't belong, or made me feel that I didn't belong, as a child. And I raise this because I think that many people have had these experiences, and you don't have to have been an immigrant to have had these experiences. You may have been discriminated against based on the color of your skin or based on the fact that you have a name that sounds different from others, or maybe that you have an accent that sounds a bit different. But those moments are, are moments where we tell people that they don't belong, and that has a very powerful effect, on our cohesion as communities, is an impact on people's mental health and their sense of psychological safety and well-being as well. I'll lastly just mention what helped, which is what helped were people, along the way, people who reminded me in those moments that I actually did belong, who reminded me that I did matter. And in 7th grade, I remember was the first time I encountered one of those people in woodshop class. And it was a class that I dreaded every day in middle school, not just because middle school as it is like one of the hardest part of a kid's life, as many of us may have experienced, but also because I had this classmate who would just relentlessly bully me, and make fun of the fact that I was Indian and my heritage. And he used to call me Gandhi at that time, which was, it obviously is a compliment in so many ways, but it was meant to be an insult. But there was this one kid, Eric Fong, in 7th grade, who actually, after 2 weeks of witnessing this, just decided that he wasn't going to put up with it anymore. And he walked across the room and he stood up to that bully and he said, "I'm not going to let you treat my friend like that. You need to shut up and sit down." And it was the first time that I felt like a moment of relief, like in that class. And again, Eric could have just sat in his chair and just like wrote out the rest of the semester. But I will always remember, even though he may not, that he stood up and reminded, not that, didn't just put that bully in his place, but reminded me that, hey, actually, I'm not the person this person says I am. So I share that just to say that as daunting and as the prospect of xenophobia and racism are, I'm reminded constantly through my experience and the experience of others that we have within us the ability to change that narrative, to change how people think, to change practice based on what we do, when we choose to speak up in the public square, when we choose to act in ways that affirm people's belonging and their sense of worth.
Yes. Thank you so much, Dr. Murthy. It's really wonderful and generous of you to share that personal story and those personal perspectives, and really to find in those experiences the positivity and a reminder for all of us, right, around our collective responsibility to remedy when we witness injustice. I want to follow up on what you were just talking about, because in this work, we do often talk about trauma, how trauma that is tied to xenophobia and discrimination can manifest not only in our mental health, but also in our physical health. Can you talk about how you see xenophobia and discrimination as relevant to conversations about health?
Oh, absolutely. And this is, Marcella, when you and I were training, I think and Marcella and I were actually in medical school together. She was senior to me then and continues to be in terms of her knowledge and experience and maturity. But I remember that, like Marcella, for you and I, like we didn't learn that much, like in medical school, about the impact of mental health on physical well-being, or about the impact of trauma, like on your overall health. And when we were going through residency training, and Marcella and I also did residency training together at Brigham and Women's Hospital, but when we were going through residency training, I feel like I was learning by observation through the stories that patients would tell us about just how much the trauma that they experienced in their lives, whether that was due to racism or that was due to other forms of emotional trauma, how much that was actually impacting their health, both their mental and physical health. And now, in 2021, we look back and we now have a growing body of data that actually affirms what so many of us were seeing in the clinic, and what many of you also just understand implicitly, which is that trauma, whether it's physical trauma or emotional trauma, has an impact on our overall health. We see that certainly in the growing body of data around children, where adverse childhood experiences and the trauma that results from that has a profound impact on a number of outcomes we care about down the line, whether it's longevity, whether it is the likelihood of developing substance use disorders or depression and anxiety or other physical illness conditions. But we also know that it plays out in older age as well. And one of the mediators actually for this is actually loneliness and isolation. Because when people experience trauma, everyone has a different response to trauma. Some people will reach out to family and friends and will seek out support and will go talk to their doctor about it and may get therapy if that's needed. People may do the full gamut of that, but I worry that the vast majority of people don't respond in that way to trauma, because for many people, trauma actually induces shame. It induces powerlessness, and it prevents you from not only seeking help, but reaching out to the people who love you, even in those moments when you need them the most. And that is perhaps one of the most damning and damaging things about trauma, is that it can begin a downward spiral for so many people. And the question is, what will break that spiral? When it comes to feeling sort of isolated or left out, which is what the experience of racism and xenophobia can do to you, not only does that chip away at people's self-worth, but it actually makes them feel like outsiders, which contributes to a sense of isolation. And what we've learned about that isolation, about that loneliness, is that it's linked to not only increases in depression and anxiety, but to shorter lifespans, to an increase in premature death, to increased incidence of dementia, to sleep disturbances, and so many other conditions. This is why, like, that body research tells us also that in the face of trauma, including deep trauma, one of the greatest sources of healing we have is actually community and connection. That it is our relationships with one another that have the power to truly heal. And if that sounds fantastic and maybe even Pollyanna-ish at times, what we know now is that that is backed up by a growing body of data that tells us that. And to me, that is empowering, because it means that you don't just need an MD behind your name, or a nursing degree, or to be a therapist in order to contribute to healing. But each of us, by virtue of the fact that we can show up in other people's lives with kindness and compassion, because we can build relationships with others, we have the ability to contribute to healing. And we are all healers in that respect. And this is a time, I think, when deep healing is needed. And if we can get people to see themselves as agents of that healing through the power of their relationship, then I think we have a good shot really at addressing some of the deep trauma that so many people have experienced in our country.
Yes, thank you so much. Kindness and compassion. So just one final question, Vivek. Congratulations again on your confirmation as Surgeon General. I think it would be very helpful for all of us if you would just take a few minutes and talk about your priorities. Tell us where you think your office will be focusing on in these coming months and administration.
Well, thank you for that. And I'll just say, look, like many offices in government, we are focused heavily on COVID-19 for the obvious reasons. I know that's why all of us are here today. But there are 3 additional issues related to COVID that have been exacerbated by COVID, but that predated COVID, that we also are prioritizing in our office. And those 3 issues include, number 1, mental health, given that there's been a surge in anxiety and depression, and for many people, loneliness during this pandemic, but those issues predated the pandemic, and in particular are affecting young people in our country. The second issue is substance use disorders. This was an area that I worked on a great deal when I was Surgeon General during the Obama administration, but what we have seen is during this pandemic, there has been a surge again in overdose deaths. And this is not shocking, because times of stress are times when people are at increased risk of relapse. But this is now, while it doesn't make the front pages of the paper every day, is an even greater crisis in some ways than it was 4 or 5 years ago. And finally, the third issue is related to why you're all here today, is equity. Is a recognition that equity is more than about providing people with equal access to care or ensuring that people have good health outcomes. Equity is a statement of value. It's a affirmation of who we choose to be as a community, of what kind of standards we choose to live by. And when I think about people like my parents who came to this country more than 4 decades ago, and why they came, there are so many of our families, again, whether we came here 150 or 200 years ago, or whether we came here recently, that came because we believed that America was a place where all people would have opportunity, where people would be treated with dignity, where they would be treated equally, and where they would be judged not based on what neighborhood they were born in or what the color of their skin was, but more so given opportunities that would allow them to work hard, to succeed based on their character, based on their work ethic. And we know that that is a vision of America that where we've made progress, but is still not realized in so many quarters. And so making sure that we are pursuing not just a COVID response, but our pursuit of better mental health, our ability to address substance use disorders with an equity focus in mind is really essential to our work. And we want to be supporting leaders like Dr. Nunez-Smith in her focus on equity. We want to ensure that that is a lens through which we not only look at issues, but a metric that we use to guide whether we are succeeding on issues, whether it's addressing the COVID pandemic or the many other public health challenges that we're facing. So those are some of the issues that we hope to focus on. But to me, at the heart of all of this is a bigger, deeper question that we have an opportunity to address right now, which affects our mental health, which affects so many of these other issues, which is a question of what kind of society do we want to design after this pandemic ends? What kind of society do we want to live in? Because if you're like me and like many other people in this country, you may have come to certain realizations during this pandemic that while, yes, we want to get to a lot of what we had before, maybe there are certain things in our lives before that maybe could have been better, maybe should be better now. Like for me, one of those is the fact that, while I believe that, relationships and community are really, really important, I realized that I wasn't prioritizing relationships and community in my life. I was prioritizing work in my life. I was making decisions about where I spend my time, effort, and energy, primarily based on work and secondarily based on the people in my life. And look, it is a luxury to be able to make that choice. First of all, there are many people who have to work 3 jobs, just to put food on the table. They don't have the luxury to say, you know what, I'm just going to prioritize my family and spend more time at home. But my dream is that one day that we will live in a society where more and more people can, in fact, make the choice to prioritize their family and live a life that is truly centered around people. But that dialogue, that conversation about how to design a truly people-centered community, how to design a people-centered life, and how to use this reset moment, which this pandemic represents, to build and design that kind of society, that to me is the central question of our time. And if we do that right, not only will we improve mental health and substance use disorder outcomes, not only will we, I think, move a giant step closer to having the kind of dialogue we need that can be a foundation for good policy and good practice, but I think we'll live a life that is truly more fulfilling for people, that brings them greater joy and happiness. And we know how deeply connected that is to our physical and mental health. So that is where we are looking to focus. It's a lot to work on, but these are important times where we all have a lot on our plate, and the pandemic for us has distilled that these issues are truly, truly at the heart of what we need to address. So we're going to apply everything we have to working on them over the next few years.
Wonderful. Thank you so much. We're all going to lean into that reset moment. I love how you framed that entire conversation and your agenda, which is ambitious, but we are grateful for it. And so, of course, as you look around, know that you have many partners here in the task force, in the work, in the mission, in the cause. As always, we are so appreciative of you centering the work in and on equity. Grateful for your time today as well. Surgeon General Vivek, thank you.
Thank you so much. I appreciate it. And thank you all again so much for all the great work you're doing and for all that you're going to do in the months ahead. Much appreciated.
Thank you. Wonderful. So grateful. And that vision that aligns so well with the work that we're doing here. And as we continue our conversation today, taking on what is not a small topic, but as the Surgeon General also just pointed out, a really critical one for us at this moment and essential for us as we begin our path towards our new and hopefully better and brighter tomorrow. So we are very honored to have joining us two, I described earlier as just luminary experts, not in the least bit hyperbolic, who will continue to provide us just the critical context we need for our conversation today. So first, it is going to be my distinct pleasure to introduce Dr. Winston Huang. Dr. Winston Huang is a scholar in residence at the UCLA Kaiser Permanente Center for Health Equity at the Fielding School of Public Health. A fellow of the American Academy of Family Practice, Dr. Huang's professional career has encompassed leadership roles, a whole host, community health centers, federal service, and most recently at Kaiser Permanente, where he served as medical director for community benefit for over 17 years. And his commitment to addressing health equity is certainly well known in this group. It's anchored by his experience as a bilingual primary care community health center physician for the Asian immigrant community in Oakland, Chinatown. In 2016, he was appointed to the HHS Office of Minority Health Advisory Committee on Minority Health, and in 2019 was appointed chair. At the National Academies of Science and Engineering and Medicine, he chairs the Roundtable on Health Equity and has served on the board of Population Health and Public Health Practice. He's the current acting CEO and chair of the National Council of Asian Pacific Islander Physicians. And in addition to his 2020 Scholar in Residence appointment at UCLA, Dr. Wong received a Doctor of Humane Letters from the A.T. Still School of Osteopathic Medicine. And that is only the beginning. Dr. Huang, thank you so much for joining us today. Please, the floor is yours.
Well, thank you, Dr. Nunez-Smith. This is a great honor and certainly a treat for me to listen to Dr. Murthy's introductory remarks. A few things before I go into the meat of my presentation. I did share with Captain Wu as well as Dr. Nunez-Smith that I'm just recovering from some major surgery. So if my voice cuts off a little bit, just ask me to speak a little bit louder. I'll try to do the best I can, but that's just a physical limitation that I have right now. I think too that I know that this committee has heard presentations from Dr. Tuong Nguyen and also Dr. Nadia Islam with regards to an overview of Asian American, Native Hawaiian, Pacific Islander COVID-19 issues. And I really would remind folks that they did excellent presentations. And my aim is really not to repeat all the substantial information that they provided over a course of a couple of presentations, but maybe to be a bit provocative in terms of how this committee should take on the questions with regards to xenophobia and with regards to some of the specific issues around Asian American, Native Hawaiian, Pacific Islander health. And the means of which I'll do that is really to ask this committee a number of questions and see kind of what provokes you in terms of your response. Respond to these questions. And pragmatic recommendations is confronted relative to COVID-19, not only for the Asian American, Native Hawaiian, Pacific Islander population, but for all communities of color. So that's really my aim today. And perhaps it'll be a bit more interactive and interesting to you than going through a number of PowerPoint presentations and slides. The other thing I will mention is that when Dr. Murthy was talking, as well as I think some other individuals here have worked with community health centers, I am reminded that in my early part of my career, I worked very intensively on issues of tuberculosis and hepatitis B among my patient population, which is mainly Asian immigrant. And many of the issues around COVID-19 are basically the same issues we had to deal with, identifying individuals that needed to go on 3-drug regimen for TB, and or that we needed to make sure that their infants would get hepatitis B immunization early on. So in some ways, COVID-19 is really epitomizes those lessons, as well as certainly accentuates some of the ongoing issues with regards to isolation of these communities and the discrimination that takes place in very operational terms. So let's go into some of these questions, and I would really encourage the committee to volunteer to provide a response to these questions that I hope you will find somewhat interesting. So the first question I have is, do you agree or do you not agree with this statement? The most Asian Americans are foreign born. How many of this would an individual offer their response to that question? Most Asian Americans are foreign born. Anyone want to provide an answer to that question? Dr. Nunez-Smith, you want to take the first question? What would you say to that?
I do not think that is true.
Well, thank you for your answer. Actually, 59% of Asian Americans actually are foreign born. And in 2018, when you looked at the census from 2010, 31% of Asian Americans had arrived to the United States in the last 10 years. Now, I say that not just in terms of trying to, pose a Jeopardy-like question, but really in terms of what this suggests with regards to the narrative, regards to Asian Americans. Because the truth is, the majority of Asian Americans are in fact foreign born. But when we lump in Native Hawaiian Pacific Islander into kind of that label, then it actually is quite misleading, because Native Hawaiian, by definition, quote, foreign born. Secondly, when you include Pacific Islanders in the Pacific Islander population category, it's actually quite broad. You do include the jurisdictions that the United States historically had since World War II had governance over, but is now contained within the Compact of Free Association. Countries that are independent, such as Palau and Micronesia, that have specific compacts with the United States with regards to immigration and assistance from the US government. Then also you include the populations of Guam, Chamorro, Saipan, et cetera. It gets actually very complicated. So my point being here, with regards to the narrative, I think we do concede, if that's the right word, that Asian Americans have a great deal of their history with regards to being recent arrivals to the United States. Now, of course, saying that and listening to Vivek's description, I do also recall that when I was a child, some of my best friends were Japanese American, and they would speak somewhat on the side to say that's when my family was in the camps. And certainly if you were to look at the Japanese American experience, there are generations of being here, as well as many, many other communities within the Asian American sector. Chinese American, including going back, helps you read this API composition. How many? Let me choose someone here who's on my screen here. Jonae Khaldun, can I ask you what would your response be to that question? Asian American family households mirror those of the typical American composition.
You're putting me on the spot.
I'm sorry.
I'm going to say no, but I'm really not sure.
Yes. Well, that's it is a loaded question, but the point here is actually upwards to 30% of Asian American, Native Hawaiian, Pacific Islander households are intergenerational, upwards to having 3 generations in one family, which is atypical of American households that are typically nuclear and 1 generation. Not, of course, this is not a hard and fast rule, but I think it is important when we consider the demographics of the population relative to how we think about COVID-19, is that when we address issues around COVID-19, is to consider the family context in which individuals come from. So you can't deal with the issues around contacts as well as screening and also follow-up around vaccination without considering really the individual within his or her household context, and that has to be incorporated. Let's go to the next question and see who will be my next fodder for the next question. Since some sectors of the healthcare workforce are composed of upwards to 20% Asian American, access to healthcare services to the AANHPI is a minor problem. So let me ask my good friend Octavio Martinez, if you're still on the call, what would your reaction be to that statement? Since some sectors of the healthcare workforce are composed of upwards to 20% Asian Americans, access is a minor problem for the Asian American population community.
And thank you, Winston. I am having some connectivity issues, so I'm hoping coming through. Can you hear me?
Yes, I can hear you well.
Okay, very good. I disagree with that statement. I think that it's not a true statement. In fact, I think when we disaggregate and we look at the different communities that make up Asian American and Pacific Islanders, there's some groups that are having some serious actually issues with access to healthcare. And there are some, though, on the higher end socioeconomic scale that one could say is pretty equivalent to probably the non-Hispanic population in access. But it's not across the board. That we have many issues we have to take into consideration, as you pointed out, because of quite a few folks are immigrants. A large percentage of the population, language issues and concordance rates of actually trying to see a provider that understands your culture is challenging.
So Octavio, thank you for that response, and I think you captured a lot of it. But I will say this, and those of you who are in the medical professions know that many of your colleagues are Asian American descent. In fact, it's about 20% of medical students are actually of Asian descent, and maybe 21% in the actual workforce when you include those who are international medical graduates. But the interesting thing is, when you look underneath this, one point you made, Octavio, was that it's misrepresented in terms of the different subgroups. So it's very difficult to find a Hmong or Min physician. It's very difficult to find a Khmer physician. But on top of that, too, even the physicians that are Asian descent, they tend to group in the specialty positions as opposed to primary care physicians. In fact, there are more Asian American physicians in the specialties proportionately than other ethnic groups. The other interesting aspect is when you ask Asian American medical students, what language do you speak other than English? The most prominent language that is identified after English as their primary language is Spanish. Which is maybe good for our country given the Spanish-speaking community, but it does also provide some misleading suggestion that the penetration of our physicians in training meet the needs of the community. Whereas 33% of the Asian American population is considered limited English proficiency. So I think we have a profound disconnect with regards to the composition of the healthcare workforce relative to the needs of the community. So let's go to the next question. We have not seen disproportionate increases in COVID mortality, morbidity within the AA Native Hawaiian Pacific Islander population. And I'm going to ask Victor, since his name sounds very much like mine, how your response would be to that question, Victor.
Okay, so I don't necessarily agree with that statement. I think that, it may not be tracked as far as data goes, but I do think there has been a high rate of infection, hospitalization, and mortality with the Asian Americans.
Thank you, Victor. Most of the data indeed suggests what you just said. Asian Americans have a case fatality rate that is disproportionately higher than the general population. And then when you look at Native Hawaiian Pacific Islanders, in many states, they are actually the group that is most likely to contract COVID-19 and to die of COVID-19. This is true in 10 states. So the data does suggest that in where good data is available, that Asian Americans, Native Hawaiian Pacific Islanders actually have a disproportionate rate of both morbidity and mortality relative to COVID-19. Let's go to the next statement. This will be interesting. The White House to examine whether the COVID virus should not be of any undue concern among the Asian American, Native Hawaiian Pacific Islander population. This is obviously a little bit more opinionated, but what would your response be to that? Let me see if there's anyone that wants to offer their opinion on that. Because this came out this week.
My apologies, Dr. Wong. I might have to ask you to repeat the statement. I think some of Dr. Wong, I think the internet might be a little
just temporarily get off video. Okay, I'm going to be off video just for a second to see if that stabilizes it.
Yes, thank you. Much better.
Okay. The statement is the White House directive to examine whether the COVID-19 virus originated at the Wuhan Virology Lab should not be of any undue concern among the Asian American, Native Hawaiian, Pacific Islander community. Ms. Yoon or Dr. Yoon, Ha-Young Yoon, can I ask your response to that question?
Sure, Dr. Winstead. I'm Young Yoon. So yeah, I do think it is concerning because I think that we've seen, sorry, I live in New York City and there's always some level of noise. Yeah, sorry. I do think it is concerning because I think that even though evidence may show whatever the outcome may be, I think that kind of connection is exactly what the former administration has driven. And I think it creates too much opportunities for people to use it in that could harm certain communities. So it is concerning.
Thank you for your comment, Ms. Yoon. And I do think this is an opinion, but I do think for the purposes of this committee, it is important to anticipate what issues may come to the forefront relative to xenophobia. And we don't have to speculate because historically, we do know that whenever international affairs occur between the United States and a country in Asia, that has direct, profound impact on the relationships for Asian Americans and the general community. All of you, I think, are familiar with the killing of Vincent Chen, who was identified as Japanese by a group of disgruntled auto workers in Michigan who associated the industrial downturn of the US car industry with Japanese inroads into the auto industry. And that impacted Mr. Chen obviously directly in terms of taking his life. But that's also true if you look at the relationship between China post-World War II, certainly the relationship between Japan and the United States during World War II that resulted in the incarceration and internment of Japanese Americans. So this is a pattern that will repeat itself, that I would ask the committee to examine and anticipate and find ways to mitigate its impact. I realize I'm coming up 20 minutes now, so Dr. Nunez-Smith, I'm going to try to do the rest of my presentation in the next 3 to 5 minutes. We'll be rushed, but I'll try to cover as much as I can.
Thank you, Dr. Wong.
The last statement is Asian American hate crimes, although reported widely, are not that prevalent in the community. How many, let me ask someone who, Mara, may I ask you, do you think that statement is true or not?
Thank you, Dr. Wong. Myra Alvarez is my name, just on the pronunciation. I actually do not think so. I think they are underreported, and there are more out there that we have yet to hear about.
Yes, according to the AAPI Center of Data Center at UC Riverside, anti-Asian hate incidents affect upwards to 2 million adults, 1 out of every 8 Asian Americans in 2020. Now, these can vary from outward violent attacks to verbal assaults to spitting, coughing, etc. But it is not uncommon for Asian Americans, Native Hawaiian Pacific Islanders to be victims of such. Now what I'm going to do in the last few minutes, because I know David is on board to give us an overview of issues around racism, and I will stay for the duration of David's remarks and be available also to answer some questions. I think some recommendations are in order, and I'm just going to provide those right now. Number one, with regards to efforts to mitigate COVID-19 among the Asian American community, Native Hawaiian Pacific Islander communities, and perhaps this has been stated earlier, but I want to emphasize our ability to mitigate COVID-19 is really very much required for us to have very intentional engagement of local leaders of diverse Asian American communities, Native Hawaiian communities, Pacific Islander communities. It was mentioned that I'm part of the National Council of Asian Pacific Islander Physicians, and we've been providing mini grants to very specific communities. For example, the Bangladeshi community in New Jersey, New York, which would not necessarily get into the public health sector. I think Dr. Marcella Smith mentioned some of this work previously, but I think it's important. The Marshallese in Arkansas, in the northwest part of Arkansas, a group that's been heavily hit by COVID-19. Native Hawaiian, not just in Hawaii, but in rural parts of Hawaii in that state. Vietnamese in Philadelphia. So this is the way that the pandemic is rolling out in terms of specific communities across Asian American, Native Hawaiian, and Pacific Islander parts of our country. I think the more proximal we get to these particular smaller groups, the more effective we are in terms of mitigating COVID-19. Just a couple more, and then I'll hand it to David. Marginalization of Asian American, Native Hawaiian Pacific Islanders is a keystone of operative discrimination of Asian American, Native Hawaiian Pacific Islanders in public health efforts. And what do I mean by this? When we marginalize the contribution, so to speak, of Asian American mortality to overall mortality rate, we effectively say that this population does not matter. When we say that not enough people speak a language that meets the certain standard requirement to reach out to these communities, we are marginalizing and effectively discriminating. When we say that the population, the community can care for its own with its own resources, we are effectively marginalizing that population. When we say we don't have enough data to reach conclusions, it provides us cover to discriminate against smaller populations that in that population itself could be quite devastating. The next point is we need to do much more with regards to understanding the history and economic and political context of Native Hawaiians and Pacific Islanders. And I hope you do spend some time in this committee to examine those issues. They're not well known, and they are frequently kind of blanketed under the large Asian American category without doing due service and due diligence in terms of understanding the dynamics of the political and economic situation of that population. Fourthly, Asian Americans in healthcare professionals are subliminally expected to subjugate any comment or perspectives they have on the discrimination they may observe in the Asian American, Native Hawaiian, Pacific Islander community, and to subsume any comment they have on any experience they have on personal attacks on their ethnic background. They are encouraged to internalize their reaction to discrimination they see in the workforce. This was well described by an editorial in JAMA about 2 weeks ago by a Taiwanese American physician who has encountered discrimination such as, I don't want a Chinese physician. And she, because she's a healthcare professional, said, well, it's up for me to be able to kind of process this without being able to get the kind of support she can from other colleagues, as well as to articulate the discrimination that she faces explicitly. And then finally, I think we need to acknowledge that Asian Americans, Native Hawaiian, Pacific Islanders are not only critical parts of essential health workers, but essential workers in general. And that we need to recognize that the prevailing narrative of a college-educated, socially mobile workforce of Asian Americans does a disservice to the diversity of different social economic backgrounds across the Asian American, Native Hawaiian, Pacific Islander population, and that this needs to be faced front very directly. That there's long-term impacts in terms of the social and economic viability of Asian Americans, Native Hawaiian, Pacific Islander populations, and reject the notion that the population is largely employed in socially secure and high-tech industries. So with that, I'm going to pause and certainly hand it over to David. I don't know if there's any quick questions I can deal with here. I will certainly stay with David's presentation and defer to Dr. Nunez-Smith in terms of how she wants to manage this part of the committee.
Thank you so much, Dr. Wong. Really appreciate that. Very grateful you can stay through Dr. Williams' presentation and the discussion that follows. So as you said, it is time to pass the baton to Dr. Williams. So grateful for you to be able to be with us today. Just let me do that brief introduction. I know we're all eager to hear your comments as well. Dr. David Williams is the Norman Professor of Public Health and Chair of the Department of Social and Behavioral Sciences at the Harvard Chan School of Public Health. He is also a professor of African and African American Studies at Harvard, the author of over 500 scientific papers. His research has addressed how race, stress, socioeconomic status, racism, health behavior, and religious involvement can affect health. He has been ranked as the most cited Black scholar in the social sciences, as one of the world's most influential scientific minds. He's an elected member of the National Academy, the American Academy of Arts and Sciences, and the National Academy of Sciences. He was a scientific advisor to the award-winning PBS film series, Unnatural Causes: Is Inequality Making Us Sick? His research has also been featured in the national print and television media and in his TED Talk. We are so grateful for all of that scholarship and for your willingness and generosity to be with us today. Dr. Williams, please, the floor is yours.
Thank you so very much, Dr. Nunes-Smith. It's truly an honor and privilege to be here, and it's really special to me to be able to see my colleague Winston Wong. We served together for the last 2 years on the Future of Nursing Committee that released its report earlier this month, and we got the bad news a few weeks ago that Dr. Wong was sick, and we were all quite stressed out about it, and so thrilled that he's well enough to be here. He's really been a great colleague. That's the most closely I've worked with him was in the context of that National Academy of Medicine panel. I'm going to share my screen so that we can jump into my presentation. I want to give you an overview of the science in terms of one aspect of racism that has consequences for health. And so I'm focused on interpersonal stress linked to experiences of racial discrimination. I have no financial conflicts to disclose, except that I have been funded by NIH for the last 3 decades plus. And the opinions that I express are my personal opinions based on the evidence that I'm citing and do not reflect the opinions of any federal agency. So when I think of racism, I think of 3 main mechanisms by which it impacts health. I think of racism as a part of the structure of society being shaped and reshaped by larger social forces. And its probably biggest impact on society is through mechanisms of institutional or structural racism. For our purposes right now, I'm using those terms interchangeably. And I have studied the role of residential segregation in shaping access to opportunity in American society. But today, I'm going to heavily talk about individual discrimination, the subjective experience of being treated unfairly or badly, recognizing that there is racism deeply embedded in our culture, which leads to implicit biases and which also triggers discrimination. I see all of these processes as interrelated and supporting each other. So what research tells us is that racial ethnic minorities on average are lower in economic status. Because of residential segregation, they tend to live in disadvantaged, segregated neighborhoods, and they have higher levels of exposure to acute and chronic stressors. So whether you're looking at financial stress or work stress, or major life events or traumatic experiences, they have higher levels of them. Not only do they have higher levels of them, some of our work suggests they have greater clustering of stresses, that if they have one, they have multiple ones. And oftentimes we think of the psychosocial and economic stressors, and we don't pay attention to the physical and chemical stressors, like exposure to air pollution, for example. All of these matter and matter profoundly for outcomes for those populations. However, I want to focus more specifically today on the fact that on top of these traditional indicators of stress, these populations also have higher levels of experiences of discrimination. The individual subjective experience of discrimination is a source of stress. And I want to review some of the science in this area for you. One measure I'm going to talk about, just in the interest of time, it's a measure I developed that's called the Everyday Discrimination Scale. Today is the most widely used measure of discrimination in health studies. One of my doctoral students doing a meta-analysis as part of a dissertation work documented there are over 450 papers published globally documenting a role of discrimination, the everyday discrimination and stress. What is striking about the Everyday Discrimination Scale is not the only measure even that I developed, because it only captures one aspect of it, little day-to-day indignities, being treated with less courtesy and respect, receiving poorer service than others in restaurants or stores, people acting as if they think you are not smart or they're afraid of you or think you are dishonest or they're better than you are. So a lot of little indignities. This is not an uncommon experience in the United States. The American Psychological Association in 2015, in their annual reports on stress in America, utilize a number of measures of discrimination that I developed, and I'm reporting here on their findings for the Everyday Discrimination Scale. This is the percent of Americans by race who experience at least one of these experiences of everyday discrimination at least once a week or almost every day. The highest level was reported by Native Americans, where 1 in 3 reported experiences those on a regular basis. You can see about 1 in 4 African Americans, about 1 in 5 Latinos, and about 1 in 10 whites and Asians reported those experiences. Importantly, not all of these experiences are necessarily experiences linked to race. The questions are not asked, did you have these experiences because of your race? They're asked globally. After an individual has endorsed them, we ask them, what do you think was the main reason? And so we can capture experiences attributed to race versus to other factors. What we have found so far in this body of research, that attribution doesn't matter. It doesn't matter whether you report experience linked to your sex or your race or your sexual orientation or your religion or your social class. Once you report those experiences, we observe negative health effects. We also find that your racial ethnic status doesn't matter in general. There are a couple exceptions to that, but the weight of the evidence is that anyone who reports them, whether you're white or black or Asian or Latino or Native American, anyone who reports these experiences have worse health, irrespective of their own racial ethnic background. What have we found for these? This slide just highlights some of the outcomes that high levels of everyday discrimination have been linked to. So studies have found higher levels of everyday discrimination are linked to incident metabolic syndrome, incident cardiovascular disease, incident breast cancer, type 2 diabetes. It's linked to higher levels of engaging in risk behaviors to soothe the negative effects of these exposures. It's linked to multiple indicators of subclinical cardiovascular disease, like intima media thickness, or coronary artery calcification, or visceral fat, or AFib, or heart rate variation. It's linked to adult onset asthma and blood pressure. It's linked to poorer sleep quality and shorter sleep duration. It's linked to multiple other indicators of biological dysregulation, like higher levels of inflammation or cortisol or lower levels of telomere length. It's linked to higher levels of obesity. It's linked to less engagement with the healthcare system and following through on physicians' recommendations, and it's linked to more mental health problems, both DSM-4 diagnosed disorders, as well as levels of emotional distress. So I have been surprised by the findings here, that these experiences of discrimination, and all of these findings are just for the everyday discrimination scale, one of multiple measures of discrimination used out there, and it just documents the pervasive adverse impact. To date, we have studies from the United States, from South Africa, from New Zealand, and from Australia that shows when you observe racial ethnic differences in health and you statistically adjust them for income and education, and that reduces the effect, but there still is a residual effect of race. When you add a measure of self-reported discrimination, you further reduce the impact of the racial gap that persists. So what I'm saying is we now have empirical evidence that everyday discrimination is an independent contributor, independent of income and education, of socioeconomic status, to racial ethnic disparities in health. There's also an emerging body of research suggesting that there are hidden ways in which stressors linked to race and racism adversely impact health. And I'll give you examples of some of those studies. One done by a former postdoctoral fellow with me at the time, Brendisha Tynes. She published the first study looking at middle and high school students in the United States and documenting high levels of discrimination in online contexts, and was able to document that high levels of online discrimination predicted increased risk of depressive symptoms and anxiety symptoms, independent of a global measure of adolescent stress and independent of experiences of discrimination in offline contexts. So just the online space is a unique contributor to experiences of discrimination and to poor mental health among adolescents. A more recent paper from Brendisha Tynes, who is now a full professor at the University of Southern California, documented among Black and Latinx adolescents ages 11 to 19, those who report higher levels of seeing someone from their racial group being arrested by the police, beaten by the police, shot by the police, report higher levels of PTSD and depressive symptoms in the following year. So again, we are seeing adverse impacts on the health of adolescents. And by the way, there is really disturbing data. So for example, if you look at data from 1990 to 2015, all suicides committed by elementary school children in the United States, the rates have been stable for Latinos and for Asian Americans. They have declined for whites. They have doubled for African Americans, which raises the question of what does it mean to be raised Black in America today, that we see a doubling of the suicide rate among elementary school children, national data for the United States among Black children. So some of these, the data on the doubling comes from looking at vital statistics, does not shed any light on what the causes are, but it does raise questions for us to think of what are the causes and the drivers of these patterns. Another issue that there is increasing research attention to is the fact that negative experiences with the police are kind of a rite of passage for many minority children in the United States, especially African American and Latinx kids. One study found that 70% of Black mothers that were interviewed said they are very concerned that their children might be harmed by the police or their children might get stopped in a predominantly white neighborhood. So these incidents then have spillover effects potentially on the health of African American adults. A study just published 2 weeks ago documented from the Fragile Family Study, a study of young people in 20 cities in the United States, that 23% of urban youth are stopped by the police by the age of 15. And that mothers of these youth who were stopped were twice as likely to report sleep difficulties linked to symptoms of depression and symptoms of anxiety. So again, mothers' mental health adversely impacted by what is happening to their children. This is another study done by myself with one of my former students and other colleagues. We looked at a database of every police shooting in the United States over a 3-year window, and then we linked it to data from the CDC on the mental health of the population in every state. And we were able to document that every police shooting of an unarmed Black person led to worse mental health of the entire Black population, not just the family and friends, but the entire Black population in the state in which it occurred for the next 3 months. So we are documenting adverse impacts of these police shootings. However, the effect was a very specific effect. It wasn't every police shooting that produced this. It was only police shootings of unarmed males or unarmed African Americans that produced the effect. If the African American were armed, then there was no negative effect on mental health, suggesting that it's the perception of a vulnerability that comes from seeing someone unarmed being shot, but also the perception of injustice and that being unfair. What are the consequences of these higher levels of exposure to psychosocial and economic stresses in general, and then on top of that, the stress of discrimination? Different words are being used in the scientific literature, like accelerated aging or premature aging or biological weathering. The notion of weathering, imagine the drop of water falling off the rooftop of the building we are sitting in onto the concrete sidewalk below. If water dripped today, it's no big deal. But if day in, day out, week in, week out, month in, month out, there's a steady drip, drip, drip of water, eventually the sidewalk would become weathered. It would become eroded as a result of the constant exposure to adversity. And what researchers suggested, research looking at biological dysregulation, research looking at telomere length and other indicators of biological aging, that middle-aged African Americans are on average in some studies 7.5 years physiologically older than whites, in some years as much as a 10-year gap in biological aging. Because what the evidence is suggesting that your age is not only capturing how long you have lived, but if you live in a bad environment, your age is also capturing how long you've been exposed to bad environmental conditions and how physiologically compromised and dysregulated you have become as a result of such exposure. And this matters profoundly then for the earlier onset of disease. There's data from the CDC showing that by age 50 to 64, but you see the pattern at every age, there's earlier onset of disease. I'm showing you only the data on high blood pressure. You can see 50 to 64, 61% of African Americans in that age group have high blood pressure compared to 41% of whites. But this pattern exists for diabetes and for kidney disease and for stroke, and it exists for a broad range of conditions. This matters profoundly for COVID-19. Here is a study of 12 New York City hospitals, almost 6,000 patients, and looking at comorbidities among those hospitalized. You can see a large number of them had hypertension, 42% with obesity, 1/3 with diabetes, 20% almost with heart disease. Importantly, what this study showed that only 6% of persons hospitalized for COVID-19 at these 12 hospitals in New York City had none of these comorbidities, and only 6% had one. So 88% had 2 or more of these comorbidities. So it's all of these stressful exposures, all of these comorbidities are factors that higher levels of stress predicts putting individuals at risk, not just for COVID-19, but for a broad range of other chronic conditions in our society. I wanted to touch base on the fact that most of the research on discrimination and health has focused historically on documenting that matters, because in the early days, researchers and even academic journals were very dismissive of the research on discrimination and health. I remember being told by a review of one of my scientific papers that the term racism does not belong in a scientific paper. The reviewer went on to explain that racism is an ideological concept that cannot be measured. So we were focused on documenting that this matters. There is a need to balance that with greater attention to identifying what are the protective factors, what are the resilience factors, what can we do? I want to just highlight some of those that have been found. One is social ties, and this is consistent with the Surgeon General's comments to us earlier, the power of social relationships. I'm illustrating it with one study that documents that power. This is the work of Gene Brody and his colleagues. He studied African-American teens in Georgia. Those high on discrimination at age 16, 17, and 18, by age 20, and note I didn't say age 40, I didn't say age 30. I said high in discrimination as a teenager. By age 20, we see higher levels of stress hormones, cortisol, epinephrine, norepinephrine, higher levels of blood pressure, higher levels of BMI, higher levels of inflammation by age 20. However, the association between discrimination and biological dysregulation at age 20 is broken among those who are high on social support, high on high quality relationships with their parents, with their teachers and their peers, showing the power of social ties to mitigate at least some of the negative effects of those exposure. A national study of African Americans found that levels, multiple aspects of religious engagement, religious attendance, influential, important support from fellow members of their congregation, as well as personal connections by seeking guidance, religious guidance in their everyday life, reduce some of the negative effects of discrimination on health. So again, religion as a potential resource. And then there's also some work that I'm not going to talk about in the interest of time, but there's work of Native American reservations that find high levels of empowerment and celebrating a sense of their own tradition and confronting the federal government. Actually, this shouldn't be, I shouldn't say Native American reservations. This was a study in Canada. So it's the First Nations in Canada also reduced the negative effects on health. So again, there is evidence of multiple aspects of resources within communities that can have a powerful effect on reducing at least some of the negative effects. The bigger challenge I think we face is identifying what can we do to reduce the occurrence of these experiences in the first place, and how can create a sense of community and respect and dignity that would avoid these experiences occurring in the first place. And I leave you with the words of Martin Luther King. True compassion is more than flinging a coin to a beggar. It understands that an edifice which produces beggars needs restructuring. And we have edifices in our society. I talked about one of them that produces racism, that has adverse impacts on health. And we need to figure out how we can best restructure them. Thank you so very much for your time and listening today.
Thank you so much, Dr. Williams. Deeply, deeply appreciated. We do have time. I'm there. Dr. Wong as well has stayed with us. Thank you both. We do have time to the task force members for any questions, comments, reflections you have for our speakers.
Dr. Nunez-Smith, I have a question for Dr. Williams, if that's possible.
Yes, Dr. Wong, please go ahead. You have our first, you may have our first question, and then Dr. Khaldoon, please after.
David, there's been, increasing suggestion with regards to post-COVID-19, post-acute syndrome relative to long-term effects of COVID-19 infection. Do you have any speculation or any suggestion with regards to whether communities of color, individuals who have been stressed by ongoing racism would have any predilection towards these long-term sequelae?
It's a great question. It's one I'm interested in. I have not done any research myself, and I have not seen any published research explicitly on this topic. But there is reason to believe that your question, that there are likely to be more adverse impacts. First of all, the evidence is clear. These are populations that have higher levels of risk, higher levels of biological vulnerability because of their exposures. On top of that, because they have higher levels of mortality, these are populations that are experiencing higher levels of grief. Grief is a well-known source of stress. And Lisa Cooper and I wrote a paper, an opinion piece in JAMA about this community bereavement and the impact it is having on these populations. And on top of that, these are populations, if you look at the Kaiser Family Fund studies, that have also been disproportionately affected by the economic stress of the pandemic. The pandemic has not only led to a loss of life and illness, but has also had negative impacts on economically. And what the research suggests, that populations of color and low-income Americans with incomes less than $40,000 of all racial ethnic groups have been disproportionately impacted. So all of this perfect storm of risk factors coming together would suggest to me that yes, they are likely to be disproportionately impacted, but I have not seen any specific data documenting that.
Thank you, Dr. Williams. Dr. Khaldoon, please.
Yes, thank you, Madam Chair, and thank you, Dr. Wong and Dr. Williams, for your engaging presentations. I have a question for Dr. Williams, specifically around maternal morbidity and mortality and infant mortality. I think we all know that there are disparities when it comes to maternal mortality, infant mortality, to all those things. We know that stress is also related to worse maternal infant health outcomes. But I wonder if you could speak to specific data that you may have seen about experiences of discrimination and racism in the healthcare system and how that's directly related to maternal health, infant mortality, and also this concept of social supports. I was lucky to have been able to implement a program when I was the Detroit Health Director that actually did this exact thing, which was build a social support community for pregnant mothers. And we saw from that program improved outcomes. But I wonder if you could speak to, I guess that was kind of two questions within one, the social supports and the discrimination and racism.
Yes. So I think social support generically, not just for the stress of discrimination and racism, but just in general for stressful life experiences, can be a powerful source. At the same time, we need to acknowledge, and the literature is clear, the early literature was just about the positive effects of social support. And there's now research looking at the fact that social relationships can provide both social support and stress, so that social relationships can also provide too many demands and can be sources of conflict. So that we do want to balance both the positive and the negative aspects of social ties. But overall, yes, there's no question social ties can be protective of a broad range of stresses, including the stress of discrimination. In terms of the effects of discrimination on maternal outcomes, there has not been a ton of research, but yes, there are some studies that link discrimination to poorer maternal outcomes. There is even a larger growing body of studies that documents experiences of discrimination reported by a pregnant woman leads to worse outcomes, not just for the mother, but for her child. So there are studies that are documenting poorer outcomes in children in the first year of life linked to maternal experiences of discrimination. There's also a body of research documenting that even parental experiences of discrimination leads to worse outcomes in their children. Both paternal and maternal experiences of discrimination. So yes, there was a wonderful review paper a few years back that reviewed some of this literature. It's called vicarious discrimination, the discrimination that parents experience that has consequences for their children. So yes, we have evidence that it matters, and there has been less effort again on identifying protective mechanisms, but yes, social ties generically is in fact an important one.
Thank you. Mr. Imperato, please.
Thank you, Madam Chair. My name is Andy Imperato. I'm with Disability Rights California, a member of the task force. Just a question both for Dr. Williams and Dr. Wong. If we think about the mental health, the long-term mental health impacts of discrimination, are there implications for the field of psychiatry and other mental health clinicians in terms of what do they need to do to respond to these types of stressors, and is traditional psychiatry enough to respond to these types of mental health stressors?
Let me jump in and then let Dr. Wong speak to it. At a minimum, what it suggests to me is that healthcare providers should screen for these experiences. I think many individuals, especially if speaking to a provider of a different race, are unlikely to volunteer these experiences. Sometimes there's some evidence to suggest that people are embarrassed by them and think that if they report them, people may think something was wrong with you. Why did they treat you that way? So they're unlikely to report them. There is a paradox of sorts in the literature of the mental health of African Americans, in that I shared with you the dramatic increase in suicide among elementary school children, and there's other evidence of increases in suicide among young African Americans. But for 100 years, African American population has had lower rates of suicide than even the white population, and the rates are still lower, although the gap is narrowing, reflecting increasing rates among young people. And that pattern has been surprising to many researchers, because you look at all the exposures African Americans have, what we see with suicide, we see with most of the common mental disorders, that African Americans have lower rates of depression and generalized anxiety disorders. And that it seems to be inconsistent with the evidence that the social context can drive these risks. However, I would say what we have found I was involved with James Jackson and other researchers at Michigan with the largest study of African American mental health and the health of Caribbean immigrants in the United States. And what we found for both African American and Caribbean immigrants, that although they had lower rates, for example, I'll show you the major depression findings, to lower rates of major depression, lifetime major depression or current rates within the last year, lower rates. Once they got depressed, though, everything was worse. So they were less likely to be depressed, but once they got depressed, their symptoms were more severe, their impairment was more severe, they were less likely to receive treatment, and their depression was more likely to be chronic and persistent. So on the one hand, there seemed to be some resources that protected from the onset, but once they got depressed, everything else was worse, suggesting that it's really important to improve access to mental health care, to reduce the stigma of mental health. Did I say they're also less likely to be treated? They were also less likely to be in treatment. I don't know if I mentioned that. And there was even lower levels of mental health treatment among Caribbean Black immigrants than among African Americans. So within both of those Black groups in the United States, thinking of what we can do to reduce the stigma of mental health and improve access is important, because we documented a very disabling pattern among those who did get depressed, for example.
Great. Thank you,
And
Dr.
Dr. Wong.
Yeah, so Dr. Wong, if you have something to add, and then I'm going to ask you, Dr. Martinez, and then Mr. Watts, to each just give your questions, and then our panelists can address both of your questions in our final moments. Dr. Wong.
Yeah, I do have a response to that. So it's a very interesting lesson I learned as a practicing primary care physician in a Chinese-speaking community. And I learned that there was no word for depression, at least in Cantonese. At the same time, I also knew, going back to the 1970s, the highest per capita risk of suicide was among elderly Chinese women in San Francisco. So there's a very interesting disconnect with regards to the phenomenon of people committing suicide, but actually not having a word to articulate depression. In addition, more recently, if you look at the rates of social isolation and individuals who say, I feel socially isolated, it is sky high among elderly Chinese women. And I think what it means to me is that the bridging of cultural competence issues and insight relative to Western frameworks of depression, there is so much work that needs to be done in that arena, not only just purely in terms of simplistic translation, but in terms of cultural understanding of how these things manifest themselves. As you may also know, that in Japan, the rates of suicide are actually quite high among younger Japanese women. So these things need to be probably addressed relative to validating that there's cultural and social science that needs to apply to classic psychiatry.
Good, thank you so much. Dr. Martinez, if you would please state your question, and then Mr. Watts.
Thank you, Madam Chair. This question is both, first, great presentations by both you, Winston and David. This question is for both of you. We've had previous subject matter experts bring data and research they've done that has showed that the perception even of community groups, including Black, Hispanic, Latino, Asian American populations compared to non-Hispanic white populations, of how well they're doing in reference to their health and even economically over the course of time seems to be much greater than what the data and the research is actually showing. So there's a disconnect between perception and the research that's being done that both of you have contributed with us today. And I'm just asking, how do we address that disconnect to truly have an informed dialogue? Because if we're perceiving we're doing much better than we really are, it really is difficult to then address these very keen and important root cause issues.
Thank you, Dr. Martinez. Mr. Watts.
Thank you both, Drs. Winston and Williams. I really appreciated the emphasis on the cultural context of understanding mental illness, and also especially about the protective factors and resilience factors. So very simply, are there, besides social ties and involvement in religion, which I imagine there's some overlap, are there other important other protective factors or resilience factors that could help us in our work?
Great. Thank you so much, Mr. Watts. Dr. Williams, if you'll start, please, and then we can give Dr. Wong the final word.
Let me say quick comments on both questions. One is, I remember a conversation I had with Kathy Newman, a great anthropologist, and she was studying African-American women in New York City and finding these women, elderly African-American women, and they had these positive sense of well-being, which didn't seem to be consistent with their objective circumstances. And one of the things she mentioned to me was that she noted part of it was the relative comparison. These were older Black women a lot of the people they grew up with had died, disproportionately so, compared to their white counterparts. And just the fact that they were alive was a source of thankfulness and gratitude, and we're glad to see a day. So, in part, what she was finding, and I haven't seen systematic attention to this was qualitative work, but that part of their higher levels of well-being and their more positive orientation was linked to the fact their comparison to others of their cohort who had not made it to the ages that they had, which makes perfect sense. Quickly on the issue of other resources, there haven't been a lot of others that have been looked at, and especially in terms of discrimination. One that there have been a couple studies of is optimism. There's some studies that find high levels of optimism predicts better outcomes. If I look at the broader literature on stress, other protective factors certainly are exercise and explicit strategies of relaxation, and gratitude is another one that has been shown to be very positive. But I haven't seen studies explicitly on discrimination that have looked at these. Thank you.
Thank you, Dr. Wong. Dr. Wong, please, final word. Oh, we can't hear you, Dr. Wong.
With regards to the issue of social context.
Oh, perhaps you can turn off your video, Dr. Wong.
And, very interesting.
Dr. Wong, are you
try again. Well, in like one of those communities. Excuse me, can you hear me?
Yes.
Okay, sorry. I was just going to mention in Okinawa, the average lifespan of individuals there, of women, is around 90 years old. And when you look at why that's so, it's because of the Okinawan approach to building community is actually quite collective and communal. And I think these are aspects that are really critical for well-being and longevity. Conversely, I think if you look at Native Hawaiian and Pacific Islander communities, for example, in Micronesia, the lifespan is very short. And this has much to do with some relationship between people in the community and the feeling that their land has been basically used and exploited by powers beyond their own community, and that there's a sense of hopelessness. So I think it's important when we look at these psychiatric issues that we place it within the social context in which people are able to thrive or not thrive. And to Octavio's point with regards to how do we fill in the gaps with regards to this, what we know and some of the facts that suggest otherwise, there's so much work that needs to be done around very robust storytelling that captures some of the critical elements of what brings well-being, as well as what brings distress, and how that is extrapolated at a collective level with regards to communities.
Thank you. Thank you. So task force members, please join me in thanking Drs. Williams and Dr. Wong for just really rich conversation. Deeply, deeply appreciative. Dr. Wong, we continue to wish you well in your recovery. Appreciate you joining us today. So thank you for that. To the task force members, we're going to take a 5-minute stretch break. All right, we're going to be back at 3:47 Eastern Standard Time. Welcome back, everyone. Captain Wu, are you on? Captain Wu?
Hi, I'm sorry.
Thank you, Captain Wu. I just will turn it over to you for one moment to complete our roll call before we move into hearing from the subcommittees, please.
Absolutely. So we have a member who joined us a little late due to a conflict. So I'll call her name and then she'll respond. Dr. Jessica Cardy-Shawn.
Here, thank you, and sorry for being late. Thank you.
Great, thank you. Thank you so much. Back to you, Madam Chair.
Thank you so much. Welcome. Thank you, everybody. So let me just take a moment again, of course, to express all my appreciation. These sprints I know are very intense in between our meetings. The subcommittees are working extremely, extremely hard along with the federal staff team before each one of these. And so just always appreciative as we get ready for these meetings for the thoughtful subcommittee recommendations that are brought forth for interim consideration. At this point, I would like to acknowledge Dr. Martha Okafor, Executive Director of the task force, and turn the floor over to you. Thank you for all your leadership. Dr. Okafor.
Thank you, Madam Chair. And before we move into the subcommittee presentation, we have a new member, ex officio member, to introduce himself. Dr. Gandhi.
Oh, thank you so much, Dr. Okafor. Welcome, Dr. Gandhi. That is my error. Dr. Gandhi, please, we're so grateful you are with us. Let us take one moment to welcome you properly, as Dr. Okafor indicated. If you could please just introduce yourself to everyone who's joining with us today. Tell us a little bit about you. We're pleased to have you.
No, I'm thrilled to be here, Madam Chair and Dr. Okafor and others. Just by way of intro, my name is Pritesh Gandhi. I'm an internist and pediatrician by training, background in public health, and prior to being appointed as the Chief Medical Officer of DHS, I was serving as the Associate Chief Medical Officer at People's Clinic. It's a innovative and committed federally qualified health center in East Austin, where we served roughly about 20,000 uninsured and underinsured Central Texans, majority of whom are newly arrived immigrant families. It's really been a privilege of my life to serve in that capacity. And so my background is in poverty and social determinants of health, access to healthcare, and really the intersection of those issues and how we think and conceptualize public policy. And so it is a pleasure to be here, privilege really to work with and learn from fellow task force members, and looking forward to working with you all in the months to come.
Wonderful. Thank you so much, Dr. Gandhi.
Thank you.
Really appreciate it. So thank you, Dr. Okafor. I will now turn the floor over to you. I appreciate you providing a process overview before introducing our subcommittee chairs. Thank you.
Thank you so much, Madam Chair, and thank you for everyone who is listening and participating via live stream. We are excited to actually be here to present to you great work that our esteemed members of the COVID-19 Health Equity Task Force had done over the month. I will ask, we can begin with the slides because then we will move through, but I wanted to share with you as we actually move forward on the slides that the topic, as some of you have heard for this sprint this month, is discrimination and xenophobia that are related, either caused by the COVID-19 pandemic or worsened by the COVID-19 pandemic. We can go to the next slide. All right, so basically, as Madam Chair mentioned, we engage a lot of subject matter experts in this work, and I just wanted to recognize them, and you will have available to you the slide, but I could just mention their names quickly. We have Jennifer Lee, Michael Krause, Sapna Sharon, Ruth Shim, Rakib Hassan, Jenna Hannibry, John Ebert, Elizabeth Crouch, Carrie Henning Smith, Serene Shabaya, Tang Nguyen, Winston Han, Bill Fletcher, Hilary Seligman, Zinzibeli, and Kamara Jones. We want to thank you for all that you've done in engaging our task force member during this month. So I will now go ahead and move to present in the next slide the overview of the task force. We recognize that some of you might be joining for the first time to listen to this, so we normally like to set the just give a level setting in terms of what the task force roles are. They are working to really execute the executive order of the president, and that executive order required them to really make recommendations on an advisory level that will enable the administration to mitigate the inequities that are caused or worsened by the COVID-19 pandemic. And their tasks are three fronts, if I could use that for those listening to kind of lean into what their work is. The first one is really during this pandemic, as we're responding to the COVID-19 pandemic, their job is to guide the nation, the administration on how to equitably respond. And they do that by looking at how the resources are being allocated and as well as how funds are being dispersed and equitably to address those inequities. Another way that they actually, another lens that they are taking is how do they advise in terms of recovery? Because while the pandemic is still evolving, we are not fully out of the woods, we are equally doing recovery efforts. So how would they actually advise in terms of the recovery being equitable to address the inequities? Some population, as you've heard already, are really disproportionately carrying that burden. So the last one is how do we make sure that the population that are disproportionately carrying the burden of inequities, that they know where those resources are, that they are engaged and they could access it so that we will definitely address those inequities in an effective manner and we could show how we are advancing equity in their health outcomes. And one way that they are looking at this aspect is also by preparing the nation for future pandemics to make sure that we have the infrastructure ready to address any future pandemics that the nation will actually face. So with that, I move to the next slide to just share with you how they are doing this work. So they most of this work are done at the subcommittee level. There are 4 subcommittees, and many of you will hear the subcommittee present the exceptional work they have done. And right now, I just want to lift up just few things that emerged across their work. One is in the area of addressing the data shortfalls, because there are data shortfalls creating some of the inequity or making it difficult for us to really assess where those inequities are happening and who's carrying what burden and to what extent. So one of the key themes that came up is really acknowledging that racial and ethnic groups are not homogeneous, and that we need to collect data that allow a more granular understanding of impact with subgroups of broader population. We give an example with AAPI and Native Hawaiian Islanders. This also is applicable to other populations like Blacks, like Hispanics. So we want to just look at that and make sure we're collecting the data. And in order to do that, another thing that came across is really having a common definition of the hate crimes and how do we standardize database so we can have an effective and robust surveillance system going forward. On the theme around expanding services in marginalized community, I'll just highlight 2 things that for you to just bear in mind, and you will hear details from the chairs when they present amazing work that they have done over the month. An example of this expansion of services in marginalized community highlights the need for us to increase investment in full services that actually support state level, territorial, tribal, community and agencies so that we are providing the services they needed, like meals in terms of food nutrition, as well as other things that they needed, housing and other important aspects of their support during any pandemic, including educational access. So we move into the next themes that I will just highlight for people that are listening. And that is, how do we engage the communities? Because of the need to be intentional in how we reach out and empower and engage the communities who are disproportionately carrying this burden of inequities. One key theme is really creating a very effective and formal partnership that will go through both the National Medical Associations, other professional organizations, as well as engaging the minoritized, the marginalized, as well as those disadvantaged communities that we need to bring into the fold. As you know, most problems have inherent solutions in the community that bear that burden. So engaging that community was a critical theme that emerged. And the last theme that I wanted to highlight is increasing awareness in terms of access to those important services. One example I will use is really combating misinformation around critical resources like vaccine, and as well as making sure that we are proactively working with the minority population, the marginalized population, and those that are minoritized, and empower them to be part of the solution and part of engaging their members of their population to access the services and resources we make available. So these are highlights of critical information, and I am so excited to begin to really introduce the subcommittee and the members, because they did all this amazing work. And I'll begin by calling on our Health Access and Quality Subcommittee. Could we move to the next slide, please? Thank you. So with great joy, I would like to introduce Tim Putnam, who is the chair for the Healthcare Access and Quality Subcommittee. And Tim, you take it away and present the outstanding work that the subcommittee has done. Thank you.
Thank you, Dr. Okafor. I appreciate it. And I represent a great group of people that have been working diligently over the last month on this topic, and have dealt with a lot of things and understanding and coalesce them to the best of our ability into the following problem statements and recommendations. The members of the committee are Myra Alvarez, Dr. James Hildreth, Vincent Toronzo, Mary Turner, Dr. Homer Venters, and Bobby Watts. I have to say a lot that they've invested a lot. They put their heart and soul into trying to coalesce everything we've learned from the subject matter experts and their own experiences into these recommendations. So if you go to the next slide, please. We have 4 problem statements. And let me just summarize these at a high level. 1, we saw marginalized populations have a reduction in access to care resources as they were shifted away from outlying facilities and clinics, treatment centers, and the resources seemed to be given to the areas with highest level of influence instead of the highest level of need. This is kind of a theme of what we've seen from a lot of subject matter experts and personal experience throughout the nation. Problem statement number 2 is many clinical processes are not calibrated to consider the entire patient population. This left clinicians either unaware or misled when they were caring for people who were not considered when the technology or the protocols were developed. Problem statement number 3 goes to when decisions for access, treatment, testing, and vaccination are based more on influence instead of the interest of public health, it creates several issues. Not only does it cause an increase in the health disparities, but it creates pockets for the disease to take a foothold and spread. It also increases distrust among the public. Public health decisions should not be made based on who has the most influence if we want to protect the public's health. And finally, the 4th recommendation really is that the tying of healthcare access and coverage to employment created 2 specific problems that manifested themselves during the pandemic. First, people displaced from jobs early on in the pandemic or ended up at best being transitioned in healthcare coverage, creating confusion, and at worst lost access to healthcare altogether. The second issue comes that areas that are economically depressed generally suffer from limited access to care to begin with, and that led more people to be vulnerable when they were exposed and contracted COVID. So those are our primary problem statements, and I will go now into the recommendations that start on the next slide. For problem statement 1, we've got 3 recommendations. We need more research focused on the impact of structural racism and biases in healthcare. This goes to things as the delivery of regions with food deserts and limited social services infrastructure. The other thing really goes to cramped housing and conditions that we saw with migrant health workers, created opportunity for the virus to gain a foothold in areas because of the issues that were associated with the housing of migrant workers and others that are forced to live in cramped housing environments. From a public health standpoint, that really created the opportunity for the disease to flourish, and that needs to be addressed. If you go to problem statement number 2, the examination and correction of policies and processes that neglect the disenfranchised populations that are not in the minority. Without aggressively addressing these processes, we default to exclude the minority. One of the examples we want to kind of bring up is with pulse oximetry, which is not as accurate for dark-skinned patients. The current technology may not allow us to correct for the differences, but the fact that it was a surprise to the clinical team, we need to make sure they're informed and aware the possibilities that the readings for some of this equipment may be less than accurate on certain populations. And this really needs to be an active process for protocols, for equipment, and it needs to be studied. It cannot just be based on the majority of the population. Next is problem statement number 3. It's important to have an apolitical authority to decide where the resources should be distributed and have those resources go to where the greatest need is to stop the spread of the disease. And this would have helped us quite a bit during the pandemic. Instead, it was apparent that many areas, these decisions were based on reasons other than the overall health of the public. And as we face pandemics in the future, we need to be able to get the resources where it will slow and stop the spread of the disease, not just be shifted to individuals that have the most influence or authority or power. And going to the final problem statement, number 4. Oh, and I apologize, go back one, I neglected the jails and prisons. They were clearly an example in problem statement number 3, where just like minority or migrant worker populations, where the disease was allowed to spread. So in problem statement number 4, tying healthcare to employment creates several problems. And again, we'll reemphasize what the committee stated last month, that not recognizing healthcare as a human right increased the inequity during the pandemic and decreased the chance of survival for many who contracted COVID. The other issues are health inequities for those who, for entities that are in rural, poor, minority populations in the country are under threat and need to be sustained. For example, every 3 weeks, we lose another rural hospital in this country. Many are cutting services that serve minority populations, that are cutting serious services that need to be offered, but they're cutting them just to stay alive and make sure they can meet payroll. The final recommendations are tied to examples for Indian Health Service and critical access hospitals as how funding needs to be increased to make sure those can still operate and serve those populations. Again, this represents the work of the entire subcommittee, and I'm going to turn it over to members of the subcommittee to comment. I'll start with Vincent Toronzo.
Thank you, Dr. Putnam, and thank you for your leadership. And I want to thank my colleagues in the subcommittee for their hard work as well. I would just like to take this time to comment on the issue with the politicization of this pandemic. And through that, we've seen a lack of equity within the COVID-19 response in several states. So what we've seen specifically is withholding vaccines and testing from communities in need, which are predominantly made up of Black and Brown populations, have resulted in these same communities being disproportionately affected by COVID-19, which has only prolonged the pandemic. So I speak in support of our recommendation where we aim to solve this issue in the case of future pandemics, that an independent authority set forth by the federal government should oversee an equitable response for the distribution of vaccines and testing kits. Thank you, Madam Chair. And I turn it over to anyone else who would like to comment.
Thank you. Might we take down the slides during this discussion portion, please? Thank you, Dr. Putnam. I yield back to you for any other members of your subcommittee who'd like to comment.
Are there any other members that would like, I mean, everybody was involved with the generation of these recommendations, and please take this time to comment.
Hi, I just have a brief comment. So thank you, Madam Chair. Thank you, Dr. Putnam, and certainly thank you to the wonderful presenters today. My name is Dr. Homer Venners, and I just wanted to briefly point out that the problem statement and recommendation about equal access for people in justice settings, carceral settings. We have today outbreaks just starting behind bars all over the country, in immigration detention, in state and federal prisons, in local county jails. And so as many of us are thinking about the resolution, the getting back to normal, there are many people that are newly exposed where the outbreaks are just starting because they have been denied equitable access to the most basic testing and vaccine because they happen to be in a detention or carceral setting. So thank you.
Thank you, Dr. Venters. And thank you to the entire subcommittee for those recommendations. Very much appreciated, Dr. Putnam and team. Would any of the other task force members care to offer comment regarding the slate of interim recommendations just proposed?
Madam Chair.
Yes, please, Dr. Hildreth.
I have a comment related to problem statement number 1. I think it's very important that we recognize that going forward, large data sets are going to be used to develop algorithms, predictive algorithms to treat various disorders and diseases. We already know that some of these algorithms are biased because the data sets used were incomplete in terms of having minority representation. So I think it's very important that going forward, we're very careful to make sure that these algorithms apply equally well to minority populations as they do to the majority population. It is a serious problem that needs to be focused on because going forward, these large data sets are going to be very important in allowing us to treat disorders. Just want to make that comment. Thank you.
Thank you very much, Dr. Hildreth. Noted. Agreed. All right. Any other comments? See no hands. I thank you again, Dr. Putnam, and the team. Very, very well done as always. Dr. Okafor.
Thank you, Madam Chair, and thank you for a remarkable work done by the Healthcare Access and Quality Subcommittee. Thank you for job great done. And I would like to introduce the next subcommittee. As we are about to show the slides, I want to take this time to introduce Myra Alvarez, who is the chair for the Communications and Collaborations subcommittee. And I have to say that get ready to hear another extraordinary recommendation, sets of recommendation presented by the members of this subcommittee. Myra?
Thank you, Dr. Okafor. And none of this work is possible without the collective effort of both our task force members and the HHS team. So we're grateful for you and all the HHS staff that are with us. I want to begin by thanking the members of our subcommittee, Andy Imperato. Wow, why am I, Octavio, I'm blanking, I blinked on your name for a second. I'm so sorry. Octavio,
we can help you, Chair Alvarez, because if we can advance the slide.
Oh yeah, please.
So we can advance your slide and here you go.
But I should have heard, so sorry. Okay, and Vincent Taranzo, as well as the full membership of the task force, our ex officio members for their thought partnership, and again, the HHS staff and interns for the incredible support. It really is a collective effort and we're grateful for that. I also do want to extend my appreciation for our speakers today and their powerful contributions to the work that we do, so thank you. Just as a quick reminder, in particular for those that are new to the task force, the Communications and Collaboration Subcommittee was created to explore how issues related to communications in all of its various forms, as well as collaborations, both within the federal government and with external state and local partners, can contribute to a more equitable response to the pandemic and future pandemics. As it relates to the challenges that we're discussing today around xenophobia and structural discrimination, and those impacts on COVID-19, the subcommittee identified 4 overarching problem statements. Next slide, please. Thanks. First, as has come up already, both by speakers and fellow task force members in the discussion, the pandemic really revealed and made worse underlying inequities in healthcare, housing, education, criminal justice, and finance systems, among others, that impact the well-being of all communities, but particularly those who are marginalized, minoritized, or medically underserved. And it's as a result of both historical and continuing structural discrimination and racism. And one thing we want to note, that includes bias amongst medical and allied health professionals. These same populations are at increased risk for COVID-19. Our second problem statement that builds on that point is that Asian American and Pacific Islander community members have been especially impacted. References to the COVID-19 pandemic by geographic location of its origin have contributed to these unfounded fears and perpetuated stigma about Asian Americans and Pacific Islanders, but it's also incited inflammatory and xenophobic rhetoric. And that together is contributing to increasing rates of violence, harassment, and hate crimes against AAPI persons, and are putting AAPI families, communities, businesses at risk. Third, our problem statement focuses on the need to recognize the national narrative, including terminology and rhetoric used by media, but also by politicians, around the portrayal of immigrants, refugees, and asylees as vectors of COVID-19, and how that terminology usage and rhetoric has led to their dehumanization and has actually contributed to more restrictive immigration policies at the state level, and more important or more relevant to our discussion is placing those populations at greater risk for COVID. And then finally, our fourth problem statement calls attention to the challenge that many Americans in our country are unaware of our country's history of structural racism and xenophobia, and how that history contributes to today's disparities in wealth, disparities in access to healthcare, education, to clean air, to clean water, and that all of those inequities are what continue to threaten the health and well-being of millions of Americans. So knowing that those were the 4 overarching challenges that we sought to address, we identified a set of recommendations to respond. Next slide, please. To respond to problem one, we have 3 recommendations. First, the federal government should lead a multi-pronged public-private awareness, education, communications campaign that's focused on 2 things: clarifying misinformation associated with vaccines and rebuilding trust in government. We suggest that such a campaign be informed by stakeholders from diverse communities so that the federal government actually has a more comprehensive understanding of incidences of misinformation that are heard in communities across the country. We also suggest that there be a robust paid media strategy moving forward so that that information is actually reaching the communities who are marginalized, minoritized, or medically underserved. Second, as part of the work to address bias amongst medical professionals, we recommend the federal government launch a formal partnership with national medical associations, as well as allied health professional organizations, so that there is a strengthened collective effort to acknowledge racism and ensure we're moving forward in an inclusive and equitable manner. Third, we recommend federal civil rights enforcement agencies develop crisis standards of care guidelines, that these be developed in partnership with states, tribes, territories, and local governments so that we can be better prepared for the next pandemic, and then we can avoid shortages that can lead to these crises. Next slide, please. And I apologize that people are doing yard work, if you can hear that. To respond to problem 2, we have 3 recommendations that seek to leverage the power of both communications and collaborations in order to address the particular discrimination directed at members of our Asian American and Pacific Islander community. So first, again, recognizing the reach of the federal government, we suggest it lead a public education campaign that educates and raises public consciousness about anti-Asian hate, and include in the campaign transparent, accurate communications directed at members of the AAPI community so that they can know that the federal government is supporting their specific access to vaccines and other related supports and services. We also recommend that the federal government collaborate with state, tribal, territorial, local law enforcement partners and community groups to educate the public about available resources related to specific pandemic-related hate or bias-related incidents, as well as best practices for reporting those incidents. And third, we recommend the federal government launch a public-private partnership to disseminate information and provide support to small businesses that are owned by Asian Americans and Pacific Islanders, and that have been disproportionately impacted by COVID-19. And we want that partnership to include small business organizations, chambers of commerce, community groups, but also ethnic media in order to best reach members of the AAPI community. Next slide, please. To respond to problem 3, we have 3 recommendations that seek to leverage the power of collaboration in particular to support immigrant communities and the disproportionate impact of the pandemic. So first, we recommend that the federal government, for example, through agencies like CDC, develop best practices for vaccination sites, particularly in areas with large immigrant communities. And this could be things from protections to culturally responsive practices to targeted messaging. Specific activities such as making sure there aren't military or National Guard or other uniformed personnel present, providing translated information on arrival, and having trained culturally competent interpreters on site. Providing other ways in which people can get this information. So it's in-person or telephonic language services, again, that advertise to limited English proficient populations, and that also provide opportunities for support in language that isn't reliant on untrained staff or other family members that don't provide interpretation unless it's an emergency. And then finally, partnerships with trusted faith and community organizations to help bridge the gap when it comes to working with immigrant communities. Next slide, please. Second, we recommend the federal government launch a formal partnership with farm worker unions to support reaching farm workers who are disproportionately from immigrant backgrounds. So this builds on one of the recommendations that Tim put forward. And this one speaks specifically to the distribution of COVID-19 related information, including vaccines and other supports and services. And then third, we recommend the federal government release specific guidance that further clarifies questions regarding immigrant communities and COVID-19. Everything from clarifying that the CDC is not going to ask for social security numbers or driver's license numbers from vaccine providers that are working with immigrant communities, to providing clarity in the base CDC data use agreement that personal data will not be inappropriately used or shared or retained and sold by third-party contractors. Again, reaffirming our commitment to ensuring the safety of all people who call the United States home. Next slide, please. And finally, to respond to problem statement 4, we're building on the expertise of many state and community leaders to identify ways in which we can reckon with our nation's history, find a path to healing, and advance equity. First, we recommend the federal government should create a Truth and Reconciliation Commission that really acknowledges the long history of racism in our country, from slavery to school segregation to policing to disability and employment and wealth disparities, and how that history continues to persist in the present, including its connection to COVID-19 inequities and the many, many millions of Americans who are victims as a result. Internationally, we've seen impacts of such efforts and believe there's opportunity for our country to make that same progress. Second, we recommend the federal government launch a robust initiative centered on uplifting the diversity of Americans and highlighting the multiple cultures, ethnicities, and backgrounds that contribute to our society today, really explaining and highlighting how equity is critical to our shared success as a country. And that builds on the Biden administration's executive order on advancing racial equity, such as the creation of an interagency task force that works across these agencies. There's already such great work happening. How can we build on that to strengthen this commitment moving forward within that lens of COVID? And then finally, to ensure we're reaching young people, we recommend the federal government partner with national youth-led organizations and influencers to increase direct education and messaging around these issues of pandemic preparedness and immunizations, specifically geared towards young people, keeping in mind those relevant channels of communication like television, online videos, educational shows, social media, again, focused on young people, their interests, their motivations, and making sure that we can reach those messages most effectively. Similar to my colleague and the ones you will hear, it's a lot of information to cover, and we value the feedback and questions. But before I hand it over to our Madam Chair to facilitate discussion, I'm going to open it up to our committee members who also have some additional thoughts and context to provide.
Thank you. Might be bring down the slides for the discussion, please.
Great. Vincent, you want to get us started?
Sure. Is that okay with you, Madam Chair? Okay, thank you. So what I'd like to just comment on is the last recommendation we made for problem statement number 4, which is surrounding youth education in terms of vaccines. So what we've seen lately is that youth education about vaccines has been lacking nationally, and it's been assumed that information flows from parent to child, but a lot of us know that it's more complicated than that, especially when you're taking into account the politicization of this pandemic. So we've made a recommendation to encourage more direct education and authentic messaging to youth populations who were largely ignored during pandemic-related communication. And this can be only explained by, early on within the COVID-19 vaccine education campaign, targeting youth populations was largely avoided, mainly because children and young adults were not labeled as risky, even though we now know that they can be carriers or even experience severe illness in some rare cases. So I know the federal government right now is moving forward with a mass vaccination campaign targeting young people. And I'd like to thank our chair, Dr. Nunez-Smith, for being a part of that campaign, doing incredible work there. And we as a subcommittee are only raising that point that we should encourage the government to further partner with national youth-led organizations and influencers, as well as young leaders within our communities who have brought the fight to COVID-19 in their own towns and cities, to increase direct education and promote authentic messaging. Thank you, Madam Chair.
Chair Alvarez, would you like to acknowledge the other members of your subcommittee?
Okay, great. Just making sure I'm doing that.
Yes, thank you.
Okay. Andy, please. Thank you, Vincent. Andy, please.
Thank you, Myra. And again, I want to just say how much I enjoy working with you and the members of the subcommittee. I just wanted to lift up the recommendation related to crisis standards of care. Myra and I are both based in California, and in our State Department of Public Health issued some draft guidelines for basically when we're making hard decisions about rationing ventilators or other scarce resources during a surge. They call that crisis standards of care. And the original guidelines they came out with in April did not have input from the disability community, from older adults, from civil rights lawyers. And we were very concerned that they were encouraging our hospitals across the state to deny people life-saving equipment and care because they were too old or too disabled to benefit from the care. And we pushed back on that, and the state came out with new guidelines in June that did not discriminate. But we feel like it's important as we prepare for the next pandemic for the expertise of the Office of Civil Rights of the U.S. Department of Health and Human Services and other civil rights enforcement agencies across government to really think through how do we allocate scarce resources without discriminating on the basis of age, disability, or any other protected class. And this is a collaboration. It's something that would benefit from people with expertise in healthcare and public health working with people with expertise in civil rights. And that's what we did in California, and we came out with better standards. So I just wanted to lift that up as an important non-discrimination recommendation.
Absolutely. Thank you. And then finally, Octavio.
Thank you, Myra. I just wanted to highlight, and really this goes across all the problem statements, the importance of communications and collaborations. The communications initiatives and collaborations, though, we're looking at it right now through an equity lens for as what the federal government could do, because these are federal recommendations. But for those that are listening and for really the general audience and all citizens of the United States, this is an opportunity really for all of us to be thinking at the community, state, the community, local, state, and federal level to truly know where we can collaborate and what kind of community initiatives we need to be doing on behalf of all our communities, where philanthropy, where nonprofits, where community organizations can come together, not only to partner with federal government, to partner with each other. We're all in this together. And I just really want to highlight how important really collaborations and the right kind of communications can be and do for us today, but also for tomorrow, as my colleagues here have been highlighting. So thank you.
Thank you so much. So those are the comments from members of our subcommittee. I will hand it back over to Madam Chair to open up discussion to the bar.
Thank you so much, Chair Alvarez. Again, much gratitude to you and the members of your subcommittee, all of them, tremendous slate of recommendations again. Would anybody like to offer comment who is a member of the task force, but it was not serving on the subcommittee? Wonderful. Thank you so much. Seeing no additional hands at this time, Dr. Okafor, I turn it over to you to introduce our next subcommittee chair, please.
Thank you, Madam Chair, and thank you, the subcommittee members of collaborations and communication for very impressive sets of recommendations. Thank you. I will use this opportunity as we show the slides one more time to introduce the next subcommittee, and that is the subcommittee that addresses data analytics and research. And just with great pleasure, I introduce Dr. Janae Caldoun, who will take us to really present extraordinary sets of recommendations. I'm so excited about the work. They're all unique, and we look forward to hearing sets of great work that your subcommittee did. Thank you, and Janae, take it away.
Thank you so much, Dr. Okafor. And of course, I also want to thank my esteemed subcommittee members for their thoughtfulness and participation in this work. Our subcommittee included Dr. James Hildreth, Mr. Andy Imperato, Mr. Victor Joseph, and Dr. Homer Venters. And also, of course, must thank Dr. Marcella Nunez-Smith for her expertise and leadership, and all of the HHS staff who really have just been amazing and champions and supporters of this work. So next slide. Our subcommittee had 5 problem statements that I will go through. The first one is really about data infrastructure and really our inability to fully capture the extent of hate incidents. And I'll say I'm pleased about the recent hate crime bill that was signed. So this is partially due to systemic racism and a subsequent lack of trust in the criminal justice system, leading really to fear and underreporting of hate crime incidents in marginalized and minoritized communities. Furthermore, these hate crime reports often don't include the full range of hate incidents. We know that not all law enforcement agencies report hate crimes to the FBI. And there's a significant delay in the release of FBI data related to hate crime. So this really creates a gap in understanding how these incidents impact our communities. The second problem statement deals particularly with the inability to completely understand how racism and discrimination have impacted minoritized and marginalized communities as it relates to their experience with the healthcare system, and also how it may have impacted COVID-19 testing, hospitalizations, and deaths. Next slide. Third, we recognize the issue of aggregated data. Again, this continues to come up and it will be a focus of this task force. And really a lack of representation of racial and ethnic groups in research. And this really inhibits, again, the ability to understand the unique experiences across racial and ethnic subgroups. Fourth, we highlight the fact that many states, as was recently discussed, lacked the ability to implement crisis standards of care, or quite frankly, had to create them in real time during the pandemic when hospitals were already becoming overwhelmed. And we are concerned that there was a lack of standardized crisis standards of care across the country, with an unknown impact on how rationing may have impacted access to care or health outcomes for marginalized, minoritized communities. In our last problem statement, we highlight the lack of tracking of health outcomes among those who are in jails, prisons, and other carceral settings. And particularly, given that we know marginalized and minoritized people are disproportionately represented in these settings, this failure to track and measure outcomes really represents racism within our public health and our healthcare system. So next slide. For our first problem statement, we had 4 recommendations. So the first one is to create a coordination mechanism on hate crime data collection, which would also include adopting a standard definition, reporting form, and also a database for reporting. And these data would also be publicized and used to inform policy. We also think communities should be supported in expanding and supporting crime reporting mechanisms. So this would include helplines, online systems, and also strategic partnerships with trusted community organizations, interagency centers, and academia. To address gaps in data, we need more robust victimization surveys to really assess the extent and causes of hate crime underreporting. And then really importantly, efforts should be made to partner with trusted community members. Again, this is a theme in the task force's communication and engagement with trusted community members, really to help build trust in the criminal justice system and also to facilitate reporting. Next slide. For problem statement 2, around discrimination in healthcare settings, we had 6 recommendations. So a national survey should be conducted to understand people's experiences of discrimination and racist acts, and specifically how COVID-19 may have impacted those experiences and subsequent health outcomes. We believe that existing national surveys, such as the Behavioral Risk Factor Surveillance Survey, the National Health Interview Survey, there are others, but they should be expanded to include questions about discrimination and people's experiences with it. And importantly, this should really include experiences across the lifespan. So we've talked about youth, we've talked about ageism, so we need to include all ages. And it also should include oversampling so that the experiences of racial and ethnic subgroups can be understood and data can be collected and disaggregated. There should also be linking of existing administrative data sets, again, emphasizing this need for more robust data that can be disaggregated. Next slide. And so we know that racism is a public health crisis. We heard earlier, it's been acknowledged by the CDC, several states and local jurisdictions. But as such, what that really means is that public health institutions and governments at the local, state, and federal level really should act by understanding the issue more robustly and responding accordingly. So that means, just like anything in public health, tracking, evaluation, reporting, and implementing prevention and mitigation measures with, importantly, the appropriate level of funding. Our fifth recommendation is that the federal government should incentivize and promote research to understand how racism and discrimination impact the way people receive healthcare services. And this again includes carceral settings, but also inpatient psychiatric settings, so places that are often missed by surveys that are currently undertaken. And we also think it's very important that people understand their civil rights. And efforts should be put forward at all levels of government to incentivize and promote efforts to educate people about their civil rights. So next slide is about problem statement 3. So the lack of, again, this concept of disaggregated data and representation of racial and ethnic groups in data and research. So we had 5 recommendations here. The federal government should support large-scale, rigorous research on the prevalence, patterns, causes, and long-term implications of COVID-related anti-Asian discrimination. And again, assuring this data is disaggregated. There should be oversampling in existing national surveys as well, again, promoting this understanding of these subgroups. We also believe the federal government should improve Asian American, Native Hawaiian, Pacific Islander, as well as American Indian and Alaskan Native representation research through inclusion and disaggregation of data. Recommendation 4, and there's a slight edit that I think didn't quite make this version, that's okay. The federal government should promote oversampling for various subgroups as well in public health surveys and research. And then again, communities have to be strong partners and engaged in data collection and research initiatives that occur within communities. So they have to be included in the governance, analysis, and developing strategies and involved in how that data is actually shared when it does involve them. So next slide. The issue of crisis standards of care. So we have one interim recommendation here, which is for the federal government to direct research to understand how crisis standards of care intersect with ableism and ageism, which has already been discussed, as well as how crisis standards were implemented throughout the pandemic and how that may have disproportionately and likely negatively impacted marginalized and minoritized populations. And then for our last problem statement around lack of health data for people in carceral settings, we had 2 recommendations. One is that the CDC and states should track and report on the health of people who are in carceral settings and implement evidence-based programs that both protect and promote their health. Again, we know that that population is disproportionately Black and Brown, and so we absolutely, from a public health standpoint, should be tracking, reporting, and implementing programs there. And second, we know that there were some interventions, such as early release, that were implemented during COVID-19, particularly to prevent COVID-19 infections and deaths. So we believe there should be research on the impact and effectiveness of these efforts. So that was a high-level overview of our interim recommendations, and I'd love to hear from my subcommittee members to chime in. And I see we have Dr. Venters. Go ahead.
Thank you, Dr. Caldoun. Thank you to the other members of the subcommittee. And again, thank you, Madam Chair, and all our presenters. I just wanted to lift up this notion that people who are incarcerated have health outcomes that we do not track. That is not new. That has been a problem for a long time. You know, the leading cause of death in US jails is suicide. But what's even more shocking than that statistic is that that data is from 2016. Imagine we would accept that lack of competent and real-time data in any other health system. We wouldn't. And so it brings me back to Surgeon General Murthy's really incredible words. Equity is a statement of values. And so the lack of equity around tracking health outcomes among people who are in carceral settings is a deep, deep reflection of the low value we have placed on their lives and their bodies. And so COVID has given us an opportunity to address this. State departments of health and the CDC have gotten a little bit more involved in vaccination, in testing. And so we have to use that involvement, not as a fleeting salve, but as a way to turn the page and bring evidence-based health structures and data to bear on a population that have been completely ignored. Thank you.
Thank you, Dr. Venters. Mr. Joseph.
Thank you, and thank you for the presentation. Unfortunately, many of the edits that we made on problem statement 3 and in the recommendations didn't make it in for whatever reason. Most of it we can look at fixing and correcting later as we get into the final report. However, when I look at problem statement 3, recommendation 4, I would like to make some amendments to it. And so if we take that problem statement or the recommendation 4, if we delete tribal right before public health, and then following that after and tribally led, so delete those 3 words, insert American Indian, Alaska Native right after promote, insert surveys after public health, and after and insert research. So it would read, the federal government should make large investments in tribal research and promote American Indian and Alaska Native oversampling in public health surveys and research. And hopefully later on we'll get all the other edits that didn't make it into this problem statement. And Dr. Khaldun, I really want to thank you for taking the effort and working with me on that. So that was much appreciated. So that's my recommendation and amendment that I would propose, Madam Chair.
Thank you so much, Mr. Joseph. We did have some version control challenges, so I do have that edit and of course for the subcommittee and others to vote on, but thank you for that.
Great. Thank you so much, Dr. Khaldun, Chair Khaldun, and the entire subcommittee. Again, we know a heavy lift, really impressive slate of recommendation. Mr. Joseph, your comments are noted. Do not think there is need for friendly amendment at this time, as it sounds like that will be resolved within the subcommittee before the final recommendation. So I would like to just at this moment open the floor for any other task force members who might want to offer comment on the recommendations that were just shared. Please, Mr. Watts, the floor is yours.
Thank you. I just really want to thank the Data and Research Committee for these great recommendations, and really want to underscore the importance of addressing the lack of data. And I don't remember which of the subject matter experts we heard during this month, but one of them, as a quote I've used since then, but that lack of data, or excuse me, missing data is a form of oppression. So it prevents us from recognizing a problem and solving a problem. So when we don't have disaggregated data, or we're missing data around race and ethnicity or other important identities, we can't solve a problem. So thank you for addressing that.
Absolutely. Thank you, Mr. Watts. Dr. Martinez.
Thank you, Madam Chair. I really want to highlight and emphasize what Dr. Venters pointed out for the incarcerated population. And additionally, especially thinking about the jails throughout this country, where there are folks that are innocent until proven guilty. They're still awaiting adjudication. And in fact, the mental health issues, as he pointed out, are significant. And these are pre-COVID issues of disparities and inequities. But COVID-19 has exacerbated that. And there's a group, community population that is incarcerated, that isn't receiving not only in mental health and physical health services, but in fact, the COVID-19 impact is not being addressed. So just pointing out, these are innocent folks until proven guilty. That is our system. And we need to ensure that all people looking through things through a health equity lens are ensured that they have opportunity to ensure that their health is taken care of. So I just really want to commend Dr. Ventures for bringing that up, but also that to me that it's also an important distinction and important point to make as well as we're thinking about enrolling and ensuring that we are addressing a pandemic in an equitable way. Thank you, Madam Chair.
Yes, thank you very much, Dr. Martinez. Wonderful. Seeing no other comments at this time, Dr. Okafor, we'll turn the floor back over to you to introduce our fourth subcommittee, please.
Thank you, Madam Chair, and I want to join the rest of the team by thanking our data analytics and research members of the subcommittee for addressing a very important factor within that lens of inequity. So I also wanted, before I introduce the next subcommittee, to echo Dr. Kadoun that, and also Dr. Joseph, that your comments, we all, there are in the version control, they just got lost in the version control issue, but those comments you just shared are in the main document. So no need for that friendly amendment is captured, just a version control issue. I also want to take the opportunity to identify that we have our ex officio members that are part of the subcommittees, and we have Dr. Rachel Levine, who is actually part of the communications and collaborations. So it wasn't mentioned, but I wanted you to know that we acknowledge your contributions as members of that subcommittee. And we will also identify other ex officio, making sure that they are equally acknowledged in the structural drivers and xenophobia subcommittee. So with that, it's really a wonderful experience to introduce our last subcommittee. Last but not the least, very important, very notable. And the reason why this subcommittee is notable is that all throughout the sprint, their focus has been on discriminations and xenophobia and structural drivers. And then everybody joined them actually this month to zero in on this topic. So it's very notable, and they will present distinctive slates of recommendations. Due to the nature of this subcommittee, it is with great pleasure I introduce Hye-Young Yoon, the chair of this subcommittee. Could we have the slides on, please? Thank you. Hye-Young.
Thank you, Dr. Okafor. So I want to begin by thanking my subcommittee members and their deep subject matter expertise, and that this month set of recommendations I'm about to present would not have been possible without their expertise. So deep gratitude to the subcommittee members. So I want to begin by saying that our subcommittee is made up of Myra Alvarez, Sarah Blige, Jessica Cardachon, Angela Hanks, Victor Joseph, Octavio Martinez, Eric Noon, Mary Turner, and Bobby Watts. Can we go to the next slides? So for those who's joining us for the first time for this public meeting, I want to underscore that in identifying our recommendations to address xenophobia and structural drivers of health inequity, we looked at the social determinants of health and well-being, like safe housing, transportation, employment, income, nutrition, to articulate the problems we're seeing across different communities and recommendations to address such problems. This month topic is huge and widespread of discrimination and xenophobia. So we have 7 problems and recommendations that accompany them. Sorry, there are lots of sirens going today. So the first problem is we know that the economic instability is ongoing for many low-income communities, and has, but Asian American, Pacific Islander, Native Hawaiian, and other communities of color have, and the businesses led by these communities are facing high rates of economic instability due to the COVID pandemic-induced recession. And I think the situation that made it harder was that there are existing structural barriers and inequities that are built into the economic recovery programs that the federal government passed that is delaying their economic recovery. So the second problem we looked at is the ongoing rise of hate incidents and discrimination faced by Asian American Pacific Islander communities. And this month we focused a little bit on both individuals and businesses because we know that the rise of anti-Asian violence had a devastating impact on the business community, AAPI business community. And then the third problem is we're looking at this month, we continue to look at the issues affecting housing for the marginalized communities that we're talking about, and really zeroed on the implicitly racially targeted policies and practices that have perpetuated greater housing insecurity and homelessness and the long-term effects of these policies. That is contributing to further poverty, denser housing, poor health and water quality, all contributing to higher rates of COVID infection and chronic diseases that many of these communities are facing. Can we go to the next slide? So fourth problem is really looking at, given the economic impact of COVID-19 and the families. In particular, we've focused on the issues and the challenges that the student community is facing and talking about what are the ways to increase access for supportive services, programs to ensure that they're meeting both health, well-being, nutritional needs, right, to mitigate the impact of COVID-19 on this community. And we also looked at in terms of other structural barriers that the immigrant communities and the student body may be facing due to the lack of certain documentation, and what are the ways to address those. The fifth problem looked at just the collapse of the caregiving system in our country due to the pandemic, right? The lack of quality and affordable childcare, and the challenges that is facing to many working families, and what are the issues that we need to address to ensure that these working families, and especially the families of color, are able to provide childcare, allow them to go back to work or remain in the workforce to support their families. The sixth problem, we focused in on the Alaskan Indian, Alaskan Natives to look at the historic underfunding and complexity of federal funding stream for these communities, and focusing on in terms of access to health, nutrition, infrastructure to ensure that they're able to recover from COVID pandemic, both in terms of public health and the economic access. Can we go to the last slide? The seventh, again, we're coming back to in terms of the disproportionate impact of COVID pandemic, and it's induced both a public health and economic crisis on women, women of color, people with disabilities, and other communities of color, and the workers and working families shoulder as a result of this economic devastation, and what these working families, workers need in order to ensure that they could recover. And then we also spent some time looking at the increased burden of unpaid care and the disproportionate impact that fell on women, women of color. Can we go to the next slide? So in terms of the first statement, first problem statement in looking at the economic instability experienced by Asian American, Pacific Islander, Native Hawaiians, and other communities of color, we came up with 3 recommendations to really do an audit of existing COVID-19 related federal government support to these communities, and especially looking at the benefits and programs that are available to Asian American Pacific Islander operated small businesses, to identify key barriers, to ensure that there is maximum utilization of these programs, to address the barriers and the effectiveness that they can have to recover from this economic crisis. The second recommendation was really looking at the farmers, the farmers in terms of the Asian American Pacific Islander farmers, and what are the programs that they're able to access that was passed as a part of the American Rescue Plan. And then I think the third recommendation is really looking at language access, really making sure that any and all programs that are available online, such as Small Business Administration, any kind of services that are available to them about financial relief, are translated into most spoken Asian languages. Right now, we believe that there's only 8, but I think it can go up to 15. Next slide, please. So the second problem is ongoing conversations we've been having at the task force in terms of what are the ways to address the rise of hate incidents and discrimination, and how to protect both the individuals and businesses who've been disproportionately impacted by the rise of anti-Asian violence and hate. So 3 recommendations here: develop and disseminate new web-based resources and trainings for state, tribal, territorial, and local law enforcement to ensure how to best identify pandemic-related hate and bias-motivated incidents. The second is to really develop and disseminate across the country best practices for reporting crimes. We know that especially in the Asian community and the fact that elderly populations have been targeted, I think there are barriers, concerns, and questions about how to best come forward to make these reports, and trying to disseminate what are the best practices, in short, how to make it easy for people who've experienced violence to come forward to report these crimes. Third, to encourage cities and states and tribes and U.S. territories to implement safe and convenient reporting channels and protocols for investigation and prosecution informed by these best practices. So the interrelatedness recommendation of the second and the third is really disseminating the information and then working with cities and states to make sure that these are implemented. Can we go to the next slide? The third problem statement is really looking at the discriminatory housing policies. Here, we've developed 4 recommendations, is to make sure that we continue to fund programs and assistance that allow people to prevent eviction, being homelessness, to make sure that there are also funds for legal services for those who are facing eviction. And the second is to strengthen enforcing housing and lending discrimination laws to make sure that we're addressing the discrimination that people may be experiencing as a result of the COVID-related structural barriers they're facing in terms of accessing housing. And the third is to really, this is much more longer, but to really increase the supply of affordable, accessible housing and supportive housing services so that people can remain in their homes. Can we go to the next slide? So this problem, fourth statement, as I said before, is really talking about the student community and what kind of supportive services and programs they need to ensure that they are thriving and are able to maintain both the health in their homes, but also in schools. So we developed 4 recommendations here. And it's really trying to make sure that the eligible schools participate in existing programs to allow high poverty schools to provide meals free of charge to all of their students. Many of these recommendations are really getting at to ensure that the existing programs are reaching those who are having a hard time accessing these programs. It also includes supporting state level cross-agency partnership to provide students with free meals during after school and summer learning enrichment programs without the requirement of additional documentation. As schools are going back and as people are coming out into the summer, it's really going to be important for students to have access to nutrition programs, services in order for them to thrive throughout the summer so that they can go back to school in the fall. Next slide, please. So this is really talking about the lack of childcare and what we need to provide families, both for the children and the working families, to provide affordable childcare, but also allowing their parents to go back to workforce for all of us to recover. So we hear 3 recommendations. So the first is really President Biden unveiled the American Families Plan to really invest in the childcare and early learning system. So really encouraging the federal government to work with Congress to make that vision a reality, to ensure that people have access to childcare. And then the second and third is again to increase funding for existing programs, to provide the after school and summer learning programs so that we have greater integration of health and social services for children, and in order for strengthening families' access to continuum of services. Can we go to the next slide? So problem 6 is really targeting the historic underfunding, and we have, I believe, these 4 recommendations, and there are additional recommendations on the next slide. Let me first go through these first 4, is to really increase funding for Indian Health Services as recommended by IHS Budget Formulation Committee, to really invest in national monitoring and surveillance system, include socially disadvantaged population to promote equity, to expand certain authority that we have to administer food assistance to determine whether all tribal children have access to the pandemic food assistance program. And the 4th is to provide, sustain, and increase funding to tribes for environmental health infrastructure, better address community needs, and prioritize delivery of necessary supplies for those who are exposed to COVID-19. Can we go to the next slide? The additional 3 recommendations to address the historic underfunding of AI and AN community is to direct more and equitable resources to Indian Health Services, to including funds to reduce administrative, cultural, linguistic barriers to healthcare, bring workforce to required level, and address health professional shortage. The 7th is to provide 1.1 billion of additional nutrition assistance to the territories as a part that was included in the American Rescue Plan to operate nutrition assistance block grants to support those hard hit by the pandemic. And the 5th is to provide funding directly to tribes and avoid using the states as mechanisms for funding and resources, honoring the government-to-government relationship. Can we go to the next slide? The 7th is really targeting the problem we lift out in terms of that women and women of color and people with disabilities and other workers of color have disproportionately shouldered the impact of the pandemic economic devastation. Here we have 3 recommendations. Again, President Biden unveiled both the American Jobs Plan and American Families Plan. And so our first recommendation is the government to work with Congress to pass the American Jobs Plan, American Families Plan, and also to work with Congress to pass a legislation called PRO Act, which would strengthen workers' rights to join a union. All of these plans will really ensure meaningful investment in our economy and mechanisms to ensure that workers have voice and power in the workplace. And then the second is we are reinforcing the importance of the federal government to issue an emergency temporary standard to protect all workers in the workplace as we're still living and working through the pandemic. And then third is to federal labor and employment agencies to dedicate more resources to investigate and prosecute anti-discrimination and other workplace violations to protect workers' rights. Now I'm going to open it up and invite other members of the subcommittee to highlight, underscore any issues that I may have missed.
Great. Thank you so much, Chair Yoon. Incredible. I mean, comprehensive. It's as Dr. Okafor said, the namesake meeting. And so thank you so much to the subcommittee for all of that very thoughtful work and deliberation. At this time, I'll invite to see if any members of the task force who did not serve on the subcommittee would like to offer comment or reflection. Seeing no additional comment, thanks again to the subcommittee. Very, very much appreciated. Okay, we will take a break in just one moment. Before we do that, I would like to ask Dr. Okafor if you would be so kind as to acknowledge the role of our student interns on the task force, please.
Thank you, Madam Chair. And I really want to, first of all, commend all our task force members. I'm just beyond words every day when we get to this time, because I know the tremendous time you guys put into this work and hours and commitment. So it's really humbling and deep gratitude to see the work culminating to these important slates of recommendation that will move the nation towards advancing equity and equitable outcomes for most population, if not all, that we are talking about and working diligently to impact their lives. So I just want to say that. And then I want to note, it's quite noteworthy and important to really recognize the interns who have been doing amazing job behind the scenes. And I just want to call them by name because I know that two of them will likely roll out of this work. And we do not want to leave this moment of just acknowledging publicly amazing work they've done. And I'll start with Yakov Green, who is the intern supporting the data analytics and research subcommittee. And then I will call on Ashley Ifadike, who is the intern supporting the work of the structural drivers and xenophobia. And I want to also mention the work that Tag Quijano has been doing with our healthcare access and quality. And then to also recognize Swati Srinivanis, who has been also helping to support, doing an amazing job also with collaborations and coordinations. We are indebted to the work you put in and all the contributions you've made to this work. And we wish the best to Ashley and Yakov, who will be rolling out. And next month, we will have their replacement to introduce them as well and just continue with this important work. Before I turn it over to you, Madam Chair, I just wanted to mention about the staff team that have been actually doing amazing work. Just to say thank you to all of them. It takes all our collective effort. And I want to mention Taylor, who has been really pulling a lot of the work behind the scene, and Min, Wayne, who has been working with us, as well as other staff team, Cherise, who has also done amazing work. I'm very happy to also mention that we have Jamie, who stepped in the middle of the sprint and had been very instrumental as well in the work. For all our partners in OASH and OMH and everybody, we just salute and with great gratitude. Thank you. I'll turn it over to you, Madam Chair.
Thank you so much. Just a great thank you for all of those folks who joined me in that task force to say, as well as congratulations to the graduating. Some of those interns of ours are now recent graduates. So congratulations to all of you. Much appreciated. Yes. We have to celebrate. So appreciation again to all the subcommittees. We will take a brief break right now. We will resume at 5:20 for public comment. 5:20 Eastern Standard Time, public comment. Welcome back, everybody. Captain Wu, let me hand it over to you, please. Thank you. If you could guide us through the public comment.
Great, thank you, Madam Chair. As with all federal advisory committees, this is an opportunity for the task force to receive comments from the members of the public. So we have received 6 requests to deliver comments for this meeting. First, we will hear from Ms. Elena An from the National AA, NH, and PI COVID-19 Policy and Response Team. Please go ahead and unmute yourself if you are on Zoom, or star 6 if you're on the phone. Ms. An, you have 3 minutes, and please proceed.
Thank you for your amazing work, your amazing equity-centered work. I'm going to focus on Asian Americans because I would like Native Hawaiian Pacific Islanders to have the opportunity to present their own experience with this issue. I presented last time the whole issue about United Against Racism and how our communities came in solidarity with Asian Americans. And when 6 Asian American women were murdered on March 16th, I worried that xenophobic racism would prevent Asian Americans throughout the United States from safely and equitably accessing the COVID vaccine. In terms of hate, the number of cumulative hate incidents reported to Stop AAPI Hate surged from 3,800 over 1 year to 6,600 in 1 month. In terms of vaccinations, the CDC reports that 11% of vaccination-eligible Asian Americans received at least 1 dose of the vaccine by March 16th, and 32% by May 27th. Kind of amazing that people got their vaccines. And I don't know the reason. I can't tell you for sure, but I can tell you that the groups that I work with, the Asian American researchers and community groups, work closely with their local health departments and with Asian Americans serving FQHCs to increase the number of vaccinations available at places that Asian Americans trusted and felt safe going to. So it's extremely important to involve them in identifying sites. It took unwavering partnership, innovative and tenacious coordination, personal drive, and concerted political will. That said, I want to thank President Biden for signing the COVID-19 Hate Crimes Act. As the act is implemented, however, I hope it will ensure equitable access for persons with limited English proficiency, limited paid time off, limited income, and limited transportation. Number 2, I would like to recommend prioritized funding for Asian American and Native Hawaiian Pacific Islander efforts aimed at achieving equitable herd immunity at the neighborhood level. According to the CDC, only 32% of vaccination-eligible Asian Americans have received at least 1 dose of the vaccine, so we still have about 40 to 68% to go. And that's why we need to prioritize funding to reach the hardest hit and the hardest to reach Asian Americans, the 6,000 hate victims, the 7.8 million limited English proficient, the 2.2 million poor, the 1.7 million undocumented, the 1.5 million uninsured, and the many Asian Americans who lack paid time off, transportation, and Wi-Fi. And I'll give you a list of programs I'd like to recommend, and I'll submit that to you in writing. Number 3, I truly value having a national dashboard where the public can go that provides COVID statistics in real time. So I was actually asked to review a COVID dashboard that scrapes race and ethnicity vaccination data directly from the states. And they told me they found that there were 8.4 million Asian Americans who received at least 1 dose of the vaccine on May 17th, or by May 17th. CDC reported 5.2 million by that same day. So there was a difference of about 3.2 million. So that made me realize how important it is for this task force, the Health and Human Services Secretary, the CDC Director, and the new Census Director to work together with experts from our respective communities to harmonize the disaggregated data that's used to guide equitable resource allocation to achieve herd immunity reopen our economies, and close the vaccination gap at all these geographic levels. So I want to thank you so much for your consideration and your time. Again, I am always in awe of your meetings. You do such amazing work, and I'm so humbled. I just have 3 minutes to give you highlights, but I will give you a detailed report. Thank you.
Thank you, Ms. Ong. Next, we will hear from Ms. Rachel Morrison from the Ethics and Public Policy Center. You have 3 minutes, and please proceed.
Hello, my name is Rachel Morrison, and I'm an attorney and a policy analyst at the Ethics and Public Policy Center, where I work on EPPC's HHS Accountability Project. Thank you for the opportunity today to provide public comment. All comments are my own, and they focus on discrimination in COVID-19 vaccine distribution. The executive order establishing this task force states that your mission and work shall be conducted consistent with applicable law. Section 1557 of the Patient Protection and Affordable Care Act guarantees that no individual can be excluded from participation in, denied benefits of, or be subject to discrimination under any federally administered or funded health program or activity because of race, color, or national origin, as prohibited under Title VI of the Civil Rights Act of 1964. HHS's website explains, programs that receive federal funds cannot distinguish among individuals on the basis of race, color, or national origin, either directly or indirectly, in the types, quantity, quality, or timeliness of program services, aids, or benefits that they provide, or the manner in which they provide them. This prohibition applies to intentional discrimination, as well as to procedures, criteria, or methods of administration that appear neutral but have a discriminatory effect on individuals because of their race, color, or national origin. States that receive federal funding for COVID-19 vaccines are subject to these non-discrimination requirements. Despite this, the focus on equity has encouraged several states to discriminate based on race, color, and national origin in their vaccine distributions by prioritizing racial minorities or Black, Indigenous, and people of color. For example, a vaccine provider in Washington state required applicants to mark whether they were a person of color or white, automatically placing all white applicants on the standby list. New Hampshire allowed Asian college students to receive the vaccine, while at the same time denying white residents in their 20s, 30s, and 40s the ability to do so. Rhode Island reserved certain vaccine doses for non-white residents only, leading to many doses being wasted when not enough racial minorities showed up, and despite demand from white residents. There are similar stories out of Montana, Vermont, and Virginia. Such actions are illegal and invidious discrimination. Just yesterday, a federal circuit court found that similar racial preferences used by the Small Business Administration in its consideration of COVID relief grant applications for restaurants were impermissible race discrimination in violation of the Equal Protection Clause of the 14th Amendment. HHS and the task force have a legal duty to prohibit race, color, and national origin discrimination, even discrimination for the purpose of equity. I urge the task force to ensure that your efforts to promote equity do not encourage or enable illegal discrimination, and to make clear to states that such discrimination in their federally funded COVID-19 vaccine programs will not be tolerated. Thank you.
Thank you, Ms. Morrison. Next, we will hear from Ms. Rakaya Yerby from the St. Louis University. You have 3 minutes, and please proceed.
Hello, thank you for allowing me to speak with you today. I am a professor of health law and the executive director of the Institute for Healing Justice and Equity at St. Louis University, which aims to eliminate disparities caused by systemic oppression and to improve individual and community health and well-being through systems change and community partnership. My academic work focuses on structural racism, which you talked about today, but I want to provide a definition and some solutions to address it throughout the COVID-19 pandemic and afterwards. So structural racism is the ways that laws, policies, and processes advantage whites while disadvantaging racial and ethnic minorities by limiting their equal access to healthcare, including the way that trade associations and institutions work together to influence the government's pandemic response, which we have seen throughout this response in terms of the lack of paid sick leave, the lack of access to clean water, the lack of access to health and safety protections. During COVID-19, racism has limited racial and ethnic minorities' equitable access to testing, treatment, and vaccines, and it continues today. Some solutions that I want to provide for you are based on the health justice framework that I have developed with Emily Benfer, Seema Malapatra, and Lindsay Wiley, which provides a mechanism for systems level transformation of government responses to health inequities, and 3 overarching principles: structural, supportive, and empowering, and really tries to integrate the social determinants of health intentionally into our pandemic response. First, interventions to address inequity must change the structures and systems of healthcare to ensure that the needs of racial and ethnic minorities are explicitly addressed to eradicate racial health inequities. For example, if the pandemic response needs to address the social determinants of health, as well as addressing the spread of the pandemic, ensuring that healthcare facilities serving these communities have the supplies and the workforce necessary to treat the higher rates of COVID-19 infections and hospitalizations, which did not occur. Second, interventions must be accompanied by legal protections, financial supports, and accommodations, including access to clean water throughout the pandemic, providing money for people to miss work if they are suffering symptoms for the vaccine. And finally, one thing that wasn't mentioned in the recommendations by the subcommittees is that these communities need to be empowered, meaning that there needs to be a national formal partnership with racial and ethnic minority communities, not just the people serving them, but the actual communities that gives them a voice and power in making these decisions. These suggestions are included in an article that we wrote together, which I've already forwarded to you. Thank you.
Thank you, Ms. Yerby. Next, we will hear from Dr. Carrie Norris from the National Hemophilia Foundation. You have 3 minutes, and please proceed.
Thank you, Captain Wu, Madam Chair, and task force members for this opportunity. I am the Vice President of Health Equity, Diversity, and Inclusion at the National Hemophilia Foundation, and our statement reads as follows. The COVID-19 pandemic has exposed deep health inequities and treatment affordability challenges that exist within our healthcare system and made it clear how much patient communities rely on copay assistance programs to afford their medications. According to a new National Hemophilia Foundation national survey of patients and caregivers, 1 in 3 of those who reported being unable to afford their medications or treatments because their copay assistance ran out was a person of color. And more than 10 respondents reported difficulty affording their prescriptions due to COVID-19. One of the strongest solutions to ensure patients and others can afford their medications is to ensure that the copay assistance that patients rely on counts towards their out-of-pocket costs. Unfortunately, nothing stops health plans from instituting policies known as copay accumulators that don't count the value of copay coupons and vouchers towards a patient deductible or out-of-pocket maximum. These policies force patients to pay higher out-of-pocket costs or even abandon their treatment. HHS and the Biden administration can take a step towards ensuring treatment affordability and health equity by requiring commercial health insurance companies to count the value of all copay assistance programs towards patient cost-sharing requirements. More than 9 out of 10 patients and caregivers surveyed by NHF agreed that the federal government should require health plans and pharmacies to count the value of copay assistance programs towards patient out-of-pocket costs. Thank you.
Thank you, Dr. Norris. Next, we will hear from Mr. John Abula from Western Illinois University. You have 3 minutes, and please proceed.
Thank you very much for the opportunity given to me to provide public comment. I'm an international graduate student at Western University, Macomb, Illinois, and an active member of the Health Equity section of the Illinois Public Health Association. But my comments are personal, not on behalf of the association. I want to encourage everyone to join hands together in reducing discrimination and xenophobia. Not just the government, but as individuals, we have roles to play. It's pertinent to realize that these issues are not peculiar to the United States alone, but they exist in various forms in different communities and nations globally. However, I am happy, and it's a good thing, that the United States is making efforts to combat these problems and find solutions to them and to reduce their effects on those affected. Today, I want to call your attention to our children. I have noticed that children are not born with the capacity to discriminate. Rather, I would say that they are born colorblind because most children interact with people easily, regardless of where they come from or how they look. So, adults need to hold themselves responsible for the attitudes that these children adopt as they grow up. Therefore, I want to suggest to everyone and to this committee that we be careful when we discuss matters related to discrimination in the presence of our children or children generally. These children get cues from us. They may not fully comprehend the details or the concepts of our conversations, but they subconsciously imbibe our attitudes and reactions. I suppose that one significant thing we can do about the issues of discrimination and xenophobia is to ensure that our children henceforth grow up with the right attitudes and better understanding of these concepts. I want to encourage the committee to look into how to influence the next generation positively through the school system and through the parents and also through the media. Likewise, I would urge us all to use the terms for what we want to see more frequently than what we do not want. By this, I mean, we should use more of these words: impartiality, fair treatment, health equity, equal rights, xenophilia in our statements. It will help to reorientate us, the listeners, and especially our children, towards what we desire and away from what we don't. Thank you very much.
Thank you, Mr. Agbula. Our last speaker is Dr. Don Garcia from Clínica Monsignor Oscar A. Romero Community Health Center. You have 3 minutes, and please proceed.
Thank you. Good day. My name is Dr. Don Garcia. I am present today as a fellow community friend and a colleague from the Los Angeles, California Latinx community. Thank you for the opportunity allowance to provide vital granular information from a Los Angeles, California local federally qualified health center. Clínica Monsignor Oscar Romero serves a marginalized primary population of undocumented and uninsured individuals from the Northern Triangle in Mexico, as well as other areas of Latin America. Today's comments are from a year of public health experience of the COVID-19 viral pandemic disaster in the Latinx population of Los Angeles County. I am a medical director at the Federally Qualified Health Center in the middle of the fire created by this viral pandemic, which Clínica Monsignor Oscar Romero has experienced since February, March of 2020, a infectivity positive rate of 35 to 40%, consistently until this early year, while the Los Angeles County rate was between 9 to 13%. This story has not been told. It needs to be repeated. The public health viral pandemic experience is one of the blue flame of the burning flame where we sit as a federally qualified health center. The Latinx community is in the middle of the fire disaster, and the buckets of water were delayed in delivery to the fire, and more often, the fire was expected to be taken to the buckets of water for extinguishing while the Latin community was being decimated. As per Joe Linda Johnson, who is the director of Equal Rights for FEMA, advice at the CDC conference, her marching orders for the federally qualified health centers were to take to the policymakers the solutions of the ground troops and boots on the ground with true viral pandemic disaster solutions not very well known by those not at ground zero. The biologic pandemic disaster has been overly traumatic, here in Los Angeles, as well as throughout the country for the Latinx community. We have the highest rates of infection, the highest rates of deaths, the highest rates of hospitalization, and yet the lowest rates of testing and vaccination in the Latinx communities, in particular, those Latinx communities who live in the highest poverty zip codes. In the highest poverty zip codes continue to suffer with the lowest rates. In summary, the Los Angeles, California Federally Qualified Health Center disaster experience with patients with the highest social insecurities, such as residency, employment benefits, to leave work to receive the vaccine without losing their job security, housing insecurity, transportation insecurity, financial insecurity, multi-generational insecurity for caretaking, language insecurity, digital technology gap insecurity, health insecurity, and most importantly, the highest risk disparities insecurity. The public health care at Clínica Monseñor Oscar Romero has been more than a necessary painstaking activity from a viral pandemic disaster, which is not experienced in other communities not served by federally qualified health centers. The participation disparity of the local neighborhood federally qualified health centers in solutions and development of policy and programs to defeat the viral pandemic is described as a disparity equal to the health disparities known to our Latinx communities of color. More importantly, there has been minimal public health attention to health literacy. Health literacy is an effective tool to extinguish the fire disaster in the Latinx communities. HHS at the CDC and is presently supported with funding by the Office of Minority Health. Yet we do not hear anything with regards to health literacy as a source of the remedy of health equities, disparities, and a racism structure of healthcare. So what is our mission today? The mission of today is for a local neighborhood Los Angeles federally qualified health center in the Latinx community to gain inclusion and not exclusion as a committed trooper to extinguish the burning fire in the Latinx communities of Los Angeles. Traditionally, historically, federally qualified health centers are not only a health services solution for our marginalized communities, but experts as well in delivering solutions for public health pandemic disasters, as well in the policy and program solutions to turn back the highest viral pandemic morbidity and mortality of the Latinx community since 1531, when the native indigenous Mexican natives experienced a viral pandemic from tuberculosis, smallpox, and measles, where 30 million of the 60 million of that population was disseminated within 30 years. Once again, we as a community are facing a repetitive history of a viral pandemic that is destroying our community. Gracias for the testimony opportunity, and I'm prepared to take and answer appropriate questions over the above presentation. Thank you again.
Thank you, Dr. Garcia. This concludes the public comment period. Please note that written comments will be accepted up to 7 days after this meeting. Please send comments to COVID-19 HETF at hhs.gov. Now, I do have an alibi. That is, closed captioning will be included in the video recording when it is posted on the website. Back to you, Madam Chair.
Thank you very much, Captain Wu, and thanks, of course, for the public comment. At this time, we'll move to vote on the interim recommendations that were presented by the subcommittees earlier. We'll be taking these recommendations up by slate, so by subcommittee. We will go in the order in which they were presented. So we will first consider the interim recommendations brought forward by the Healthcare Access and Quality Subcommittee. Do I have a motion?
Motion, Madam Chair.
Thank you very much, Dr. Putnam. Do I have a second? Dr. Hildreth? Thank you very much. Any further discussion? Seeing none, all in favor of the slate of interim recommendations from the subcommittee, please signal by saying, by raising your hand. Yay, thank you. Thank you very much. I believe that is unanimous. Right? No nays. Any abstentions? Okay, I vote yes. That carries. Thank you very much. The second slate of recommendations we will consider are from the Communications and Collaboration Subcommittee. Do I have a motion?
So moved.
Thank you very much, Dr. Calderon. Do I have a second?
Second.
Ms. Alvarez, thank you. Second. Any further discussion, please? Okay, hearing none. All in favor, please signal by raising your hand. All right. Thank you very much. I believe that was also unanimous. I vote yes. Thank you. Motion carries. Okay, let us consider the slate of interim recommendations brought forward by the Data Analytics and Research Subcommittee, please. Do I have a motion?
So moved.
Thank you very much, Mr. Imperato. Do I hear a second?
Second.
Thank you, Mr. Joseph. Right. Any further discussion? Seeing none. Please signal your vote by raise of hand. Yeas. Thank you once again. Since all members have voted yay, I vote yes. Thank you, motion carries. And lastly, let us take up the consideration of the interim recommendations brought forward by the Structural Drivers and Xenophobia Subcommittee. Do I have a motion?
So moved.
Thank you very much, Mr. Joseph. Do I have a second?
Second.
Was that Mr. Taranza?
Yes.
Thank you very much. Second, do we have any further discussion? Seeing none, please indicate your vote by show of hand. Yeas, please. Thank you very much. I also vote yes. That motion also carries. Much appreciation. Another month of incredible work. Thank you so much. All of the subcommittee recommendations that were presented today have just been approved by the full task force. Will return to the respective subcommittees for continued work and deliberation before being finalized for that final report. So I will just take a quick moment just to express my gratitude to everyone for the work that is involved in this task force and in generating these recommendations. I want to thank everyone for participating in this, which was our fourth meeting. An extra special thank you, of course, to each of the subcommittee chairs, to each task force member. As always, you have set the bar very, very high. We have come to expect these extremely thoughtful and actionable interim recommendations for our group deliberation. I want to thank, of course, our guest today, Surgeon General Vivek Murthy, as well as Drs. Wong, Dr. Williams. Thank you to Dr. Okafor, our Executive Director, to Captain Wu, our DFO, yes, to the entire federal staff team. It takes so many people, as Dr. Okafor said, to support this work. So there's deep gratitude. Let me thank you as well. I saw our ASL interpreters hard at work. Thank you for that. So as we look ahead, our next meeting will focus on long COVID, as well as equitable access to PPE, to testing, and to therapies. The date and time of the next meeting are provided in the meeting notice. Look for that in the Federal Register, as well as on the task force website. So I'll close out by saying thank you everyone for joining. Please do enjoy a very safe holiday weekend as we remember and honor the fallen. Meeting adjourned.